Good morning, everyone. We'll start today's work session on Thursday, February 27th, 2024. Excuse me, 25. I'm not going to go back in time. For the record, I am State Representative Maureen Mooney of the town of Merrimack. I am the Vice Chair of Division 3 on the House Finance Committee. Our Chairman, Representative Jess Edwards, cannot be with us today, but I'm sure he's watching on YouTube. Today's work session was published in the House calendar as well as outside of this room, so we do have a publicly noticed work session. Just a reminder that the materials we work from are found a few places online. The LBA site, which is off of the General Court website, that's the Legislative Budget Assistance webpage, as well as the Department of Administrative Services. They have a very comprehensive web page there of the materials we work from. Our deadline, we're looking to get out our version with amendments and so forth by the end of March 26th or so. And then House Bills 1 and 2 should be out of the full House by April 3rd, early April. I would ask members of the committee to take notes as we go along. I'm not going to take motions. We're not going to have votes in the division today. And then that the presenters, of course, make it clear what page and accounting unit we're working from, as well as highlighting for us any prioritized needs and vacancies, which have been reoccurring questions as we go throughout these budget lines. All right, with that, any comments from our members of Division 3 at this point? Okay, I'm glad to see everybody, and I'm glad everybody arrived safely. I know the weather is not on our side this morning, so I know it took tremendous efforts of both committee members and members of the audience and presenters. So we thank you very much for making yourselves available on a snowy morning to be with us today. The work session is entitled Budget Work Session, Division of Behavioral Health. Depending on how far we go this morning, we'll consider, when to take our lunch break. You let us know what's good for you in the 12:30 range of things, I'm thinking. And let us know, too, if the flow of what we do, questions throughout your presentation, works for you or not. We can always adjust that. So with that, welcome to Division 3, and you may start at your leisure.
Good morning. I'm Katya Fox. I'm the director of the Division for Behavioral Health.
Good morning. Nathan White, Chief Financial Officer of the Department of Health and Human Services. This morning, as always, there's 3 documents in front of you. The first is the PowerPoint presentation. That's the colored document there in front of you. There's also the budget briefing book for the Division for Behavioral Health. And then just as a reminder, we talked about this yesterday, the only accounting units included in the briefing book are those in excess of $1 million annually. And then within the governor's operating budget, we'll be looking at pages 988 through 1014. And with that said, I will hand it over to Katya.
Thank you. I want to note that I am here to answer your questions, and hopefully by the end of our session, I'll have been able to do that. If not, I also have some staff in the audience, and we'll ask them to contribute if they have their responses on the spot. And of course, we'll follow up with any questions that we're unable to answer today. Also, I wanted to note that we have about 60 pages to get through. So I know we have a 6-hour block today with a lunch break. There is one duplicate slide that is towards the end, and I'll point that out when we get there. I also want to know, as we go through this, that we're going to be looking at some numbers, and you're going to be seeing some differences between actuals and adjusted authorized in 24 and 25. And then you're going to see some significant swings in 26 and 27. And that's because of some changes that we made in accounting units. So no huge additional funds or decrease in funds for our bureau. For our division in the bureaus. So with that, I'll start. As always, the department has each division have a mission and vision statement. And our mission is to cultivate the mental health and wellness of all individuals by promoting thriving and resilient communities and ensuring all people in New Hampshire have access to high quality integrated care for optimum mental health. And our vision is that we have a continuum that is individual and family driven, embraces innovation and overcomes challenges, is trusted and valued, and brings hope and connection to communities statewide. And I have to say, this may seem just routine. Oh, yeah, there's another mission statement and vision. But this takes lots of time and lots of discussion among our staff and with inputs from our stakeholders. So every single word has been parsed as we have put this before you today. So from a division perspective, we have oversight and guidance to ensure that we have mental health, substance use, and homeless services across the state that align with our mission and our vision. We have technical assistance and training, so we provide that across the department as well as other state agencies and throughout the state. And then we have monitoring and quality assurance, making sure that we have the data and that we have that drive what we're doing. And that's for all programs and initiatives and levels of care. And then, of course, overseeing our programs through our contracts with our hundreds and hundreds of providers across the state. So, sorry, I should say slide 4. So what is the division? Who is the division? We have 4 bureaus within our division. We have mental health services, which addresses the adult population. We have children's behavioral health. We have the Bureau of Drug and Alcohol Services and the Bureau of Homeless Services. And then sitting side by side with that is the policy unit that looks and assists across the entire division. So we have a system of care. I know system of care is used a lot. We talked about it yesterday with the system of care for children. I know that there are other areas of the department that use that, but it really is addressing comprehensive care for people across the lifespan. And how do we do that? I mentioned the contracting. We have workforce development, training and technical assistance, the oversight and performance monitoring, infrastructure development, which was key over the last several years to infuse the resources into making sure we have the bedrock upon which all of our services are built upon, and policy. So we go through the continuum. We look at community education and awareness, prevention and early intervention, peer recovery, which is something that is really key and important to the work that we do, community-based supports and services, and then we get to the higher level of services that are needed for more complex cases, which include residential treatment and housing supports, crisis services, and inpatient services. No, because I wrote my notes on this. So then on page 5, we have our positions and where they fall. On page 6, we start going into the accounting units. And I'm going to probably lean a little bit on Nathan when it comes to this, but for our 988 grant, which is on the budget book page number 988, we have two contracts. We have a contract with Headrest, which is our primary lead for our lifeline for the 988 number that you call. That's the call center. And then we also have a technical assistance contract with UNH. In the Office of the Director, there are no contracts. That's where me and my staff sit. Choose Love, you may remember this program from a couple years ago. That was transferred, I believe it was in the governor's office, and then transferred into our agency, sits at the division level, and that is staffing.
Representative Nelevanko for a question.
Thank you, Madam Chair. Ms. Fox, what is the nature of the technical service with UNH? What do they provide? What does technical mean in your world?
Yeah, so they provide stakeholder convening, so administrative functions, and they do continuous process improvement when they look at the data and some data collection for us. And-
So would I be correcting, it's kind of a consulting service?
Yeah, yeah. I think we use them interchangeably, so I can try to correct for that.
And that, what is the value of that contract?
I have it here, but I'll need, maybe during a break I can get it to you, and Nathan's
sure.
gonna look for it right now.
Thank you.
The next one is the Medicaid payments to New Hampshire Hospital and Glencliff. These are the federal funds where they land in our account from historic perspective and do not stay within. They're somewhat of a pass-through and a place where those funds come into. And then, of course, unemployment compensation.
Representative Priest for a question.
Thank you, Madam Chairman. Going back to your program, Choose Love, can you just define that? What is that?
Sure. So that was a program that was established in the governor's office under Governor Sununu, and it is a program that was born from the tragedy in Connecticut with the school shooting. And so the founder was a mom of a child who was in that who was killed in that horrible tragedy. And it's about building resilience in communities, in schools, in children, and addressing how we can go about regulating emotions and conducting ourselves from a strength-based perspective rather than from what was viewed as a hateful perspective.
Thank you.
Just to follow up on that, when was that implemented in New Hampshire, that program? How old is it?
Yeah, I was going to say Newtown happened so it happened shortly after that. So about 6 years ago, but we can double check.
Thank you.
Yeah. So slide 7. So this again is from a division perspective about the key accomplishments over the last couple of years. We have integrated crisis services available. So this isn't just to address mental health, but also to address substance use crises. So we have the New Hampshire Rapid Response Access Point, and that is the centralized location where people can call for help when they're experiencing a mental health crisis or substance misuse crisis, and it also deploys the mobile crisis units across the state. And you can see from the numbers, whenever we had data, we tried to include it in these slides so that you had an idea of the scope and the reach of these services. And there'll be more data that I'll be showing a little bit later on. We have rapid response crisis centers. So when you look at the crisis system, you want a place to call, you want someone to respond, and you want a place to go should you need it. And so there have been 2 that have been opened. Again, we'll get a little bit more into this a little bit later on. And then we have something that was in the last few years that have been developed, which is the cold weather homeless responses. So these are either shelters or a way a community can address the bitter cold winter months by opening warming centers and having other options for people experiencing homelessness.
Representative Priest for question.
Thank you, Madam Chairman. And again, I apologize. Welcome, Ms. Fox. Back to the Rapid Response Crisis Stabilization Centers. How many visits did you have last year?
I'm going to get to the data. For the crisis stabilization centers.
Yes.
They have just opened. So
They just have opened.
yeah, yep, they have just opened. So we have some information about one of them. The other just opened a couple of weeks ago.
Okay. What about the cold weather homeless responses? How many people?
I think I have that data later in the deck.
Okay, thank you.
Yeah, these, what we tried to do here was do the highlights, and then we'll go into more details later on in the
Thank you.
presentation. So another key accomplishment was we increased housing options and supports. As you know, there has been a real crunch for housing across the board for everybody. But despite that, we've been able to increase options for individuals with a behavioral health condition. And we'll get, again, these are highlights. We'll get more into the details of the numbers and what types of housing as we go along. Slide 8. So I know that you've already heard from Medicaid as well as DCYF. So there's a lot of information that they shared that also pops up here. And we've been participating with Medicaid on initiatives to improve access to care. And so there was an opportunity through our federal partner, who is SAMHSA, as well as through the Centers for Medicare and Medicaid, to establish certified community behavioral health clinics. These are clinics that have the ability to serve people with substance misuse disorder as well as mental health. And again, we're going to get into this a little bit later on in the presentation. And there's the community reentry, which I believe that Director Littman spoke about. And that's for having Medicaid services available prior to someone being released from prison, so that they are connected to the community and more likely to stay and have community tenure with those support services as soon as they reenter the community. And then we, as I mentioned earlier, we have the infrastructure investments that we've made. So the one-time funds that we had, we were able to infuse those into our systems to really be foundational as we go forward. Right now, and again, we'll be talking about these a little bit more, we have an assessment going on for the Children's System of Care. We had the ability to stand up a crisis responder certification program. And so this was a way to work with our community college system and being able to give the training for the workforce that's needed as we expand these services. And we also had a peer certification program that was established.
Representative Nelevenko for question.
Yeah, thank you, Madam Chair. Thank you, Ms. Fox. So could you kind of describe what the peer certification program is and how does that compare to, professional certification or?
Right. So we'll get into peer services, but the peer certification program is really to, again, give credentials and ensure that we have the quality that we want in the delivery of the workforce. And it gives options for peers for entering the workforce and having the ability to be a peer and be recognized as a peer in their setting.
Is that in addition to or in lieu of formal training programs within your division?
It is in addition to.
Thank you.
All right, so that's the division perspective, and then we're going to go right into the bureaus. So we're doing pretty well. I think I'm ahead of, if I look at slide count and the time, we're doing okay. So I know there was discussion about this yesterday with the Division for Children, Youth, and Families. Okay.
Oh, Representative Priest for question.
Yes, going back on the peer certification, how are the individuals chosen for this program?
They choose
They
to enter.
choose.
Yeah, just like any other certification program that you may want to take and be involved in.
Is this just with the state employees or businesses?
No, this is for the community-based services. And so it allows someone who is a person with lived experience to go through a training program and learn how to have, it's all like boundaries and how to help somebody navigate a system. It's a lot of that, but it's really for the communities and for our community-based organizations, not for the state.
So you just make the announcement that you have this program and, okay, thank you.
Yes, yeah.
Representative Tulersky for a question.
Thanks for taking my question. It's occurring to me that although I know about the peer support, are these peer counselors, I don't even know what you call the mentors, let's say, are they volunteers?
They are not. So the idea of the certification program is so they can land a job in the field.
Okay. Thanks.
Okay. So Bureau for Children's Behavioral Health. Again, I know you spoke some of this yesterday with Director Noonan presenting, and so some of it may be repetitive, and I tried to listen in, so I heard some of the questions that came up, and hopefully I can address some of those. So on page 10, you'll see the accounting units. And I'm trying to think of where my notes are, not right in front of me for the contracts that are affiliated with this, but I think that most of them fall into 2053. So one thing I should point out is you notice there are only 2 accounting units, so there aren't a lot, and that all of our contracts fall within, I believe, the system of care. That's all out of system of care. Yeah. Okay. So the system of care account is where all of our contracted services appear. And so we contract with our community mental health centers. We contract with our care management entities. We have New Hampshire Rapid Response, which I mentioned before. Some of the funds come out of this account. And our residential programs for children. Sorry, I need to dial a friend here. And so I I have 21 pages of contracts, by the way, so I printed them out, but rather than fumble through those, I looked to Nathan instead. So that's where all of the children's services are budgeted.
Representative Wallner for a question.
Good time to ask some questions about the budget.
Sure.
So this is just a really quick one, but on page 1000, I saw that on line on 50, you had almost $500,000 worth of temporary staff during this year, and it goes away next year.
Yeah, so those dollars will not be spent. I
Okay.
believe what this represents is from HB 1573. There was $1 million appropriation that was made, and those funds are non-lapsing. And because of the timing and the work and effort that's required to go through the process to create positions and then actually hire those positions, and then given the current status, we don't anticipate spending all of that. So that money is actually being carried forward into this biennium, but you're not going to see necessarily those dollars budgeted here because those dollars were continually appropriated non-lapsing for that specific purpose.
Remind me what 1573 was.
So that is the oversight of the children's residential. And so that,
Okay.
yeah.
Okay.
Yeah.
And then when we go down to page 10,001 or 1001, in your contracts, are there any rate increases for any of the programs?
So as we go through this, we can sprinkle it throughout or we can do a summary, but there was a prioritized need for rate increases for residential, and that was not funded in this current budget. I'm sorry, it was partially, no, that was in rates. Yeah. It was, the rate increases were not funded. The other thing of note is that I wanted to point out, because I figured you would pick up on it pretty quickly, on that page of 1001, with the total amount in the system of care in 2053, you see the authorized adjusted 33.6 million, and then it goes significantly down. The reason for that is because that funding was for children's residential rate increases from the last biennium for the current biennium. And all of the dollars were put into this account. So this was a way for us to have an account to deposit all those funds to account for them. They are now budgeted in the appropriate places. So they're in the Medicaid budget, they're in DCYF. So we have not had a $10 million cut to children's system of care. We've had improved accounting for the services.
And this goes back to our conversation yesterday where the team's working on a crosswalk so that we can give you better insight and be able to follow the bouncing ball, so to speak, through this 3 separate accounting units.
So I just have one more about rates. So providers got a rate in the biennium that we're in, but not into the next. There's no rate increase written in here for the.
Correct.
Okay, thank you.
And there actually is one reduction that I should just note, that the Children's Behavioral Health Resource Center is not funded in this budget. And so there is that about $1 million that was reduced in this budget.
Representative Priest for a question.
Thank you, Madam Chairman. And just as a follow-up to the following question, what was the reduction?
Yes. So again, disbursement of the about $9 million to other accounts, and then $1 million for the Behavioral Health Children's Resource Center that I'm going to get to when you'll see that in one of the slides.
Okay, thank you.
Representative Nalavanko for a question.
Yes, thanks, Madam Chair. Maybe you're going to cover this later, but in looking at, I'm looking at page 11 on all the various services. So kind of a sensitive subject that's come to the fore recently is the whole question of gender dysphoria. And I'm wondering how much of that you're seeing and where it's covered and how that manifests itself in the behavioral health area.
So I'm not quite sure how to answer it as it pertains to,
Well, the first question is, are you seeing a lot of that in terms of behavioral health across the wide spectrum of age groups and gender groups that you see?
I would say when you look at national statistics, you can see of who's at increased risk for suicide, suicide attempts, and vulnerable populations, that we see some of that data that indicates that there are certain people who have an increased risk. And so I don't know how I would label it other than there are some young adults and children who struggle as a result and have those increased risks.
So just a quick follow-up. Where does that fall in terms of the wheel I'm looking at on, and and how does that manifest itself in terms of referrals and other aspects of that?
I would say that it falls in each one of these without any statistics to back it up. I would say that when we start to see it, as with most community-based services, it's when that you start seeing it on the acute end. When something becomes a crisis is when we notice. I'm just talking in general, not specific to this.
Thank you.
All right, I guess we're on page 11. This is a wheel. I think you're getting used to seeing these from us as we go through the different tiers and we look at different levels of services. And we always start out with the population-based services, and then we go through the wheel and have the acute side going all the way up. This has been something that we've used for the Children's System of Care pretty much since its inception. What's really important to note is how many youth are being served in community-based settings. Because we hear about the acute settings, we focus on that, but really most people are being served and youth are being served in their communities. And as you heard from Director Noonan yesterday about all the efforts to keep children and youth in their communities through kinship care, through their families with family supports, and when necessary, through foster care.
Representative Priest for a question.
Thank you, Madam Chairman. Do you have an actual number for this? You said 95% of the youth. Do you have an actual number that how many individuals?
We probably, yes, but I don't have it here.
Could you also find, when you go back to get that number, the number of youths that you have serviced in previous years to see if you're getting out to the community and you're making a difference?
Yeah, that's a really good question. When you look at the data, does an increase mean, is it good because we did a better job of reaching families, or is it an indication that we are somehow failing to provide the services, those community-based services? So it's always great to look at the data and then ask ourselves those questions as we look at it and we think about funding.
But you will come back with those actual numbers? so
Yeah,
that
and
we
you're going to
can?
see them actually in our rapid response numbers.
Okay,
in the
great.
deck.
Thank you.
Okay, this one doesn't have a number, but it's 12. And this is looking and further describing those tiered services. So prevention and early intervention, we do the assessment and evaluation, screenings, and those are looked at as a universal way to to that early identification for services. To the far right, you see the community-based services and supports. Those are tiers 2 and 3, and then in the middle, tier 3 as well. So you look at all those types, we start going from a population-based approach to the individual-based approach, and then start looking at those specialty services that are needed for specific circumstances. All right, slide 13. This is the Children's Behavioral Health Resource Center, which we were required to stand up and have done so. That was under, it's now RSA 135F. And this center links children, families, community members to the services and the providers that they need, resources that they need. And the Resource Center also provides training for providers on these issues. And that's what the center is.
Representative Telersky for a question.
So to clarify, you said previously this is not funded in the governor's budget.
Correct.
Great, thank you.
Representative Nelvanko for a question.
Yes, thank you, Madam Chair. I just want to come back to page 12 for a second and ask a couple of quick questions on a couple of these programs. What is the Fast Forward program?
That is a great question. I shouldn't have glossed over that. And again, I think we have some statistics that indicate more about that program. It is a high fidelity wraparound service that is for children and youth, and it is delivered in the community. So they're individually developed through a service plan with the family and with those youth.
So again, a follow-up. I'm unfamiliar with a lot of the terminology.
Yeah.
But what, so you mentioned that ties into the high fidelity wraparound, which maybe you could give a couple of words of what that translates to.
Sure, it's coordinating everybody who's touching a family and really getting them to all be working together for the shared goal for that family. So it's when we say wraparound, it's really not having a bunch of different places where people need to go, but really having that care coordination that needs to happen as people go through and navigate the system.
And if I may, indulge me for one more. On medication management, how exactly, what does that mean? Does that mean who are you working with, or who, how are you managing medications?
So I'm going to have to take that back because I don't know on the ground exactly how that happens. I do know that in certain circumstances in our community mental health system, the medications are dispensed in a controlled way with a family to ensure compliance and or adherence to dosages and things like that. But I can get more.
Is it also working with schools, or, because down here you have educational and development services, is that the medication management in conjunction with, I don't know, the school system?
It could be, yes.
Thank you.
Representative Wallner for a question.
Thank you. So I heard you say that the Resource Center is not going to be continued. It's not funded in the next budget.
Right.
And I wondered, could you talk just for a second about who is that going to affect? And is the reason it was chosen to not be funded because it wasn't used? Or for what reason was the decision made that you wouldn't fund it in the next budget?
So hard decisions are being made about budgets right now. So I'm not really going to comment on any one aspect of our budget and any reduction as to why, other than we all know that we're facing a shortfall in revenue and that not everything can continue as is. And so what we're thinking as we go forward is that this is a service that we could bring in-house should we be able to have the staffing for it. It's the maintenance of a website. What we lose is the provider training specifically as a result. The Resource Center also is about making those connections for families in communities. And as you'll see, we have a campaign that was pretty successful known as Strong as Granite. We need to think about using such approaches as well as what we've used for 988 and rapid response in going forward on how can we reach families. And we have done trainings and we'll continue to do trainings with our field staff within DCYF and juvenile justice and making sure that this information is available for families.
Thank you.
Representative Priest, followed by Representative Stringham.
Thank you, Madam Chairman. Back to the Children's Behavior Health Resource Center. How many years was that in operation, and how many clients did you serve?
So I don't think I brought the stats on the numbers, but we'll double check on that. I think Nathan's going to check on that hopefully for me. It has only been up and running for less than 2 years. I would say. I might be wrong on that, but front facing from a community perspective, I think it's been about 2 years.
As a follow-up, as another question, on page 12, do you have actual numbers of individuals that you served in the community-based services and support that you could share with us
Yes.
from 2024 and previous 5 years? So we can
Yes.
see.
If it's not in the briefing book, then we will make sure you get that.
Thank you.
Good morning, Director Fox. Good to see you again. Thanks for joining us. It sounds, I didn't see anything, later on you talk about your prioritized needs and what's been funded and what's not. I didn't see anything on there on the Resource Center. So can you comment about if it was continued, what kind of a budget appropriation that would involve? Thanks.
Sure. And so what we've tried to do at the request of Representative Wallner is include all of our prioritized needs that were not funded in there. If it were to be funded, what we had originally budgeted was $1 million of general funds each year, so for a grand total of $2 million over the biennium.
And there's a possibility you could bring that work in-house, use either available or additional staff, perhaps at a far lower cost. Is that?
I would hope that it doesn't come to that, but yes, we would consider bringing it in-house because it's required by state law that we have this center. And we would ask for additional resources to be able to do that because, as you know, the current budget unfunds positions. And so we're having less staff. And so to bring something in-house requires more staff, or at least a position to be filled. The other thing is the ability to have that reference technical assistance, to have that training for providers. That is not something that we could do in-house. So we would lose that unless we were able to contract with someone to provide that. And it's really about looking at programs that are of high quality and producing those.
Just jumping ahead, how many of the 60 or so staff are unfunded positions right now in this division?
Sure. So I would have to manually go through my notes here, but I can tell you for 20052 for children's behavioral health, 3 of the 9 full-time authorized positions you're looking at in the 26-27 budget are currently unfunded. And there's a total of 10 positions across the entire division that are unfunded today.
Representative Talarsky, followed by Representative Seaworth for questions.
Thank you. Quick question. Since the Children's Behavioral Health Resource Center is required by law, do you happen to have the RSA just from our notes, or is that asking too much?
I believe it landed in 135F.
Thank you.
Thank you, Madam Chair. That was actually my question. As a follow-up, did the governor's draft of HB2 have to alter or defer that law in order to adjust the budget?
The current draft of HB2 does not modify that. I think I'd need to take a closer look at the statute to determine whether that would need to be or not. But
All right. So I believe we're up to slide 15. Is that correct? No,
That's-
okay, 14.
Sure.
Yeah, 14.
14.
Yep. And this was just a follow-up on the resource center. They have done surveys and they've assessed particular programs, and part of that is this is just to let you know that we are measuring and looking at the involvement of the community-based services and what impact it has on children and their families, and their positive outcomes. And so you can see those there. We do have the statistics that we'll go into starting on slide 15. So early childhood wraparound, we talked about fast forward before. This is the same exact concept, but it targets children who are birth to 5. And I remember when we first started this program, everyone's like, someone at birth, how could you identify that they have a mental health condition? And really, this is about that early detection and early family supports and having the support. So it's really looking at the caregivers and how those wraparound services can help the whole family through this process. So this is a Medicaid funded service. So we received approval to be able to cover these services. And this, you can see the growth over time. What I'm going to be showing you are statistics that show slow, steady progress. And I think that's really important because when we think about fundamental changes to our system, the idea of just flooding a system, saying shutting down residential programs and having them all go community-based would not be able to be done on a dime. It needs to be incremental as we go through and do it in a very measured and capacity building and the utilization in this steady way. So this steady growth is great from my perspective because we're able to have the proof of concept go from 8 in July of 22 to the 63 that we have in January. And so again, I think it's a good sign that we're adding and continuing to grow, but not so rapidly that we're overwhelming any particular community provider or any service.
Representative Nelevanko for a question.
Yeah, very quick question. Come back to the ages birth to 5. So I assume that, and if I'm incorrect, that would apply to mothers that are substance addicted.
Yes.
And then the question is, how much of that do you see, and how do you get those referrals?
Yeah, so that's a great question. So yes, that's a very good description of the situations that people are facing. We have many PCPs who will identify that, so primary care physicians. We have hospitals that are working with a family or come across a family. We have, it could be a sibling situation with a family that's known to a community. It could be schools. So there are many referral sources for these programs.
And just a quick follow-up. So with all of the, evidence of problems with all kinds of drugs in New Hampshire, are we seeing an increase in those kinds of referrals and any kind of numbers that you might put on that?
Yeah, so referrals, you're seeing actually numbers served. I'm not sure if we included it here, but we also do numbers of referrals so that you can see over time the demand for those services and for the increased knowledge. Again, we do those trainings and we do that outreach specifically to our field staff for DCYF and for juvenile justice and others. But I don't have those numbers here for the referrals. But that is a good point, and it's really important that people, once they have been identified and they identify themselves as having a need, that we're able to meet that need.
So if you could provide at least some rough numbers on
Sure.
that particular portion of the referrals, would be interested to see that.
Absolutely. And that's something that we share with Children's Oversight on a monthly basis, and can certainly share it here.
Thank you.
And so page 16 is fast forward. So this is the population that we talked about earlier, which is 5 to 21. And again, you can see that growth. This program has been, I'm sorry, slide 16. Oh, 15. Okay. All right, my numbers are off, and that's why he had said, "Do you want the actual colored copy?" So, so when I printed it, I'm off. So I'm sorry for that. But this one's talking about fast forward. So we're on slide 15. Again, growth of the system. We've seen the growth in the referrals and then the enrollments. This is delivered by our care management entities, and we have 2 of them. So that's why you see the 2 different line graphs in the bars.
Representative Stringham for a question.
I just noticed, you have different, number served since 2015. The other one was 23. Does that represent the start date of those particular services?
Absolutely, yes. Yeah, and so that's why you can see Fast Forward came well before the early childhood wraparound, which we recently added based on the success of Fast Forward.
Representative Priest for a question.
Thank you, Madam Chairman. Ms. Fox, do you have the referrals to the Fast Forward enrollments?
We do.
Could you provide that to us?
Yes.
Thank you.
Okay.
Yes, all set. Thank you.
Okay. So the next slide, I believe, is 16. I'll get back on track with this, is transitional enhanced care coordination. So this is specific.
No, you were right.
Okay, now I'm back on track. All right, everyone I think knows where I am. So the TREC program is how we refer to it. And this is specific for youth and families, for the youth who are transitioning in or out of a residential treatment program or a psychiatric hospitalization, say at Hampstead, for example. And this is the ability for that oversight and the coordination of care through that transition process. Many of the services that I'm talking about, and I'll be talking about later as well, is that those transitions are one of the most important points of contact and level of service that are make a difference, because that's where we lose people, so to speak, where we have a gap, and then they get disconnected from services. So this program oversees the those transitions and helps in making sure that as those transitions happen, that all of the services are in place upon discharge from a residential or a psychiatric acute setting.
Representative Daniels for a question.
Yes. As we look at this chart, how are we supposed to know how many are transitioning in or out?
In or out, that I don't think you can figure it out from this. So I can get that for you of how many. I think what you'll see is that they will follow someone pre-entry into residential treatment if they're identified early enough, and then post as well. For example, if there is a youth at the Sununu Center, we know that they're going to be there. And so those services prior to will be touching base and understanding the family dynamics and the youth situation, and that there are some touch points when someone is within that setting, and then when they come out, they pick them up. So that it's not just like, okay, you're there. They maintain that contact throughout that episode. So I think there are going to be situations where that happens, and then there'll be other situations where the first time we come into contact with a family is when their youth or child ends up in a acute setting. So I think you'll have a mix of both, and I'll see if we can parse that out for you.
Okay, and I guess just for your information, what I'm trying to look for is the success rate.
Yeah.
I mean, we've heard that being able to move them out of residential into the community is more of a success. But as I look at the charts, it looks like your numbers are continually growing. And you've presented that as a positive thing. But, I'm sitting here saying, are we seeing any successes? I would think that if we were doing things right, that maybe we would see the numbers start to go down.
I agree. And again, it's really hard to, when we look at the data, to determine what we consider success versus what is not successful. And that can be because we've reached out to more families, and there are more families who are now aware of our services, or is it because there's a problem? So I totally get it. Yeah.
Thank you.
Representative Nalavanko, followed by Representative Priest.
Thank you, Madam Chair. Thank you, Ms. Fox, for taking the question. We earlier touched on, briefly on the question of suicide and suicide prevention. And so I'm just wondering, does your division track suicides in the context of cases that you're dealing with over time?
So there is a suicide prevention council that is established by statute, and they issue an annual report that has data, and it has the ages broken down, and that information comes from our chief examiner's office, our medical examiner's office, and that's data that's pulled together. And so if you'd like a copy of that report, I can make sure you get it.
Yeah, I was just interested whether we're seeing, a lot of it, a little of it, and what the trends
Yeah.
look like.
Yeah.
Okay.
We can get
Thank you.
that for you.
Representative Priest.
Thank you, Madam Chairman, and thank you, Ms. Fox, for taking my question. I would like to applaud you and your department for getting more and more people who have needs to come and seek and get treatment for that. How many referrals do you have, and how many people do you have to turn away because you do not have the residential facilities to handle them?
So we're going to get a little bit more into the residential settings in a couple slides, and you'll see that.
How many referrals? How many referrals do you have for this particular program?
So it's interesting because when you say referral, it's not just, okay, a referral, it's a screening assessment, determination of a level of care. So there
see.
may be someone who needs a residential specific level
Right.
or a specialty service.
Right.
So,
okay.
so I'm not quite sure if I
No,
can
you've
answer it.
answered, yeah, you've clarified my question. Thank you very much.
Okay. All right, page 18. This is exactly where we're going next. We're talking about residential treatment. This is a report that we issue monthly, or we can do at point in time. And this gives you a sense of where our youth are and our children are in residential treatment at any point. So we have the programs that are in New Hampshire that you're familiar with. So there's Nashua Children's Home, Dover, Spalding, Easter Seals. You start to hear these names and you can think about them as you think about your communities and what services you have in your communities. So we have the New Hampshire programs, and you'll see the numbers there of how many children and youth are in those facilities. We have those in New England and primarily in Vermont, Massachusetts, and Maine. And then we have national programs, which we've heard a lot about. So we have, as of the point in time when this data was pulled in early February, 339 children who are in residential care. And then I can give you a minute just to look at some of the data rather than reading it to you, but you can look at the age breakdown, the case type, which you can tie back to the DCYF presentation yesterday, and then the levels of care, which go all the way up to the PRTF, which in New Hampshire we have a PRTF at Hampstead Hospital.
Representative Talerski for a question.
Just a quick question about the different case situations, knowing that our hope is to have our kids home. Can you just talk about what kind of needs those 8 children have that are so significantly far away? Like, what are some of these situations that require this?
The one that comes to mind most quickly is the situation where you may have someone who has a medical need. So they're medically fragile. They may have some type of condition that isn't necessarily controlled, as well as the mental health condition. So they have multiple needs. It's hard when we have a specialty case to have a program, a full program that has the ability to stand up when you have one particular case. So if you think of some of the cases of, and I really shouldn't call them cases, they're families, they're kids, they're our neighbors. They have such complex needs where they may have an intellectual disorder, a mental health condition, a physical need, some type of disability, and there just isn't any specialized program for that to address that. They may have an eating disorder is another one that we think of. So those are really the outliers, those cases. And it's really important that we have a place for them to get the treatment that they need. And that's why we do have to rely on those national programs.
So does New Hampshire have a quality program for eating disorders, or did they have to go somewhere else in New England?
That's typically out of state.
That's too bad. Okay, thank you.
With regard to the age ranges there on page 18, do you know if those numbers are average in terms of numbers in those age categories? Are they above average, below? Any idea where we stand?
So from a national perspective, is that your question?
I'm thinking more in state. But it's okay if you don't. I was just curious, especially in terms of the 0 to 4 range and the 5 to 11, if those were above average or
Yeah, I would need to get back to you on that.
No problem.
As you see, most of the population falls into that teenage population.
Right.
The 12 to 17.
okay, no problem. Thank you. Okay, Representative Seaworth, followed by Representative Priest.
Thank you very much. So you mentioned the connection with this presentation with what we heard yesterday, and I certainly remember some of the numbers line up. If I'm now thinking about the budget, and let's say I'm looking at the cost for the 8 out of state, is this going to be spread among different budgets? How do I connect funding to the kids rather than the departments?
You want to be able to track costs by child?
And not in, that makes it sound like I want to do more than I really want to do, just when I'm trying to get my mind around the total cost of this thing. How do I know that I'm looking at all the different places that funds it? So it may be just a high level of how the funding crosses between departments for a single purpose.
Sure. And that's that analysis or that compilation that we're working on. And again, to Katya's point, it's based on the specific needs of the child and what the child is eligible for. So if they're eligible for Medicaid, then the service portion could be paid for with Medicaid. But the room and board, if they're not eligible for TANF or 4E, then that may be 100% general funds. But if they're eligible for TANF, then the room and board and education are paid with TANF and potentially, and then, but then the services may be paid for with TANF instead of Medicaid. And so I have a matrix that the team's put together over the years to try to simply explain that. And I think that's one of the challenges with the way that we're currently looking at this. And we've already started to have internal conversations around like going forward in future years, is there an easier way that we can budget this to give the legislature better insight and ourselves better insight in order to be able to track this consistently? So, right now I'm anticipating a change for the next biennium because we want to be transparent and be able to demonstrate this. And that's that document that we'll have for you next week. So I can try to get to your question a little bit more directly.
Okay, thank you very much. That's
course.
exactly what I'm thinking.
Thank you, Madam Chairman. Back to page 15. Is this for fiscal year 24 or the numbers that you have provided us?
I want to make sure I'm on the right. Yeah, this is for state fiscal year 23 is what we have here.
23. Do you,
Oh, since 23. I'm sorry.
since 23?
Yeah, yep. So if you look, it goes from July of 22 all the way through to January of 25.
Okay. So it starts out in 14.
So that's since the birth of the program, so to
Okay,
speak.
great. Thank you very much.
Representative Nelavanko for a question.
Yeah, it's just a follow-up question to Representative Seaworth's question. So his question was fundamentally an accounting question, but the other side of this is I'd be interested to know out of the 8, what the range, what the range of costs was lowest to highest for that group of 8. And that would obviously, have some correlation to how the accounting shakes out on that. Without any identifying individuals or anything, but it's just looking at lowest to highest and median, recognizing that each one of these cases is unique.
Sure. That would probably be a large amount of manual work because each child is going to have different needs. They're going to be they're going to be potentially at different placement locations that have different rates. And then you're going to have a different mix of funding, and the start and the end dates are all going to be different. So one case may be for 3 months, one may be for 9 months, one may be for some other period of time. So it would likely be a fairly in-depth analysis because as Marie Noonan, the DCYF director, was saying yesterday, the Bridges system that we use to track some of these expenses for these children, it came out in 1997. And so as I've been saying internally, that's the heyday of AOL. I mean, it's a very antiquated system and we're working on revising that. So we're not able to pull reports in real time quickly to be able to get to that level of detail. It could be done manually with quite a bit of work.
Well, I'm kind of surprised at that because you have a case number assigned to each individual and costs associated with that case, I would assume. So this is a very high level thing. And if you're tracking it that way, all you're looking for is a gross kind of a range. So I'm not sure I understand why. I'm not looking for a lot of detail. I'm looking really for high level numbers.
Like a sample of 10?
Well, it's a sample of 8 here, I guess, in this particular case.
Okay, sure.
Yeah, thank you.
All right. So page 19. So this is the assessment that I referenced earlier, and as part of the roadmap for the department, we identified the need to look at the system of care. It has been 8 years or so that it's been established, and it was time to take another look and see how are we doing? How are we providing those services? Are we meeting the needs? What are the gaps? And how do we go about better coordinating the system of care? And so we have been working to do that. We have stakeholder input, and we will be getting and issuing a final report in the next month or so. And so we look forward to that and appreciate everybody who has contributed to that effort. Okay, that is the system of care and the Children's Bureau. I'm going to move now, and the reason why this comes next is because the children's system is served by this service, by Rapid Response and Integrated Services. And so you're not seeing a new bureau show up here because, again, it's part of the division-wide approach to crisis services for all populations.
Representative Stringham for a question.
Yeah, just make sure I understand all those different services, the 5-level residential treatments, in-state, out-of-state, out of New England, all those things are contained in those 2 departments that we first went through and managed by 9 people, 3 which positions are currently unfunded and unfilled. Is that correct?
Yes, however, we do have the DCYF, which is overseeing the cases. So the ones that the youth and children are involved in, we have DCYF as a co-partner. So they're doing visits with families and they're doing all the work that they do in the community. So I don't want to say that, 6 people are doing all of this work. I will say for the residential program, we have 3 staff that are dedicated to that. And then, as Nathan mentioned earlier, the HB 1573 increased the oversight for residential programs, and we had hoped to have 2 positions created as part of that, and as a way to, in the interim, is that we're providing overtime so that we can increase the amount of visits that we have from a quality perspective for those residential settings.
Representative Tulersky for a question.
Thanks. Yesterday afternoon, when we were having a conversation with DCYF, I don't believe you were here, but there was a question from Representative Nalavenko about how do we reduce the numbers of kids who are affected? And the answer sort of boiled down to family resources and system of care. Do you want to speak on that with this program as prevention and getting ahead of situations before they end up in the system?
Absolutely. Our division serves the community, that we're all community-based services. The idea of any reliance on any inpatient or residential program, we want to reduce it as much as we can. We know that what works, you've seen some of our statistics. There are other programs that are making a big difference for families. And we want to continue those efforts, double those efforts. We want to focus on what works, and that's why we're doing the assessment to determine what other gaps we can fill at the community level. And there will always be a population that needs acute services, that needs residential services. We can't just make it go away and think that the community can absorb the need. And we need further training. We need further tools to be able to help families address the needs of their loved ones. Okay. So, rapid response. Again, we've talked about this quite a bit, I think, from the last biennium into this biennium, and the program continues to mature. It is, we call it New Hampshire Rapid Response. We have an access point, which is the phone number that you call, and then we have mobile crisis units. A lot of people think this is just as mobile crisis, but they're all part of that program that is to address when someone's in an acute crisis. And so we have that access point. That is the 24/7 call. You can text and do a chat. There are initial assessments. You quickly get on the phone and find out what the need is. Sometimes it's information and referral. Other times it's an acute crisis that does not need 911 response, but is for that person on the phone right then an emergency. So the access point coordinates when a response is needed. So they make the determination whether or not there needs to be a mobile deployment into the community. And so that assessment's made. And then if needed, mobile crisis is deployed. The 10 community mental health centers deliver the mobile crisis services. It's a statewide approach so that you may have, for example, in Manchester, you may have more than one need for a mobile deployment at once. So at the same time, so you would have your nearest mental health center deploy their mobile unit to address that second. So while we have regions, we have a statewide approach to the mobile crisis response.
Representative Nelevanko for a question.
Yes, thank you, Madam Chair. Thank you, Ms. Fox. I'm wondering if I trying to understand the little asterisk on the bottom of page 20 that says the crisis model is funded through state general funds, but then it goes on to say is a requirement of the federal community mental health block grant.
Yeah.
So
Yeah, it's a little confusing. I saw that this morning when I was reviewing, and I'm glad you asked that so I can clarify. So it's required that we take our block grant dollars that we receive from SAMHSA for our mental health block grant, and we have a set aside. So they give us, I forget how much million it's in here, dollars, but then they say of that amount, 5% must be spent on crisis response. So this is our spending, meeting that requirement. So we do have general funds, we have the requirement of the block grant that we spend that 5% set aside.
And we've referred to that as maintenance of effort requirement previously when we've talked about that, where we have to expend X amount of general funds in order to continue to receive the federal block grant.
okay, so then roughly how much of the, how much of this is funded federal money and how much of it is general fund money? And how can I,
Yeah, we have that, and it's in our contract. It has the spread of where that comes from, so we'll be able to get that for you.
Okay.
It's primarily general funds when it comes to the access point. When it comes to the mobile crisis response, the deployment of the unit, that is more likely to be Medicaid billable.
okay, thank you.
Okay, and then the third pillar for the integrated crisis response is somewhere to go. And this was a gap and a need that we identified pretty quickly. It's great that you can have a mobile deployment, but there are situations in which someone you respond to may not have anywhere to go from there. And so the idea is to have a crisis center where someone can go for 23.5 hours. Otherwise, you fall into licensing requirements. But the idea is that you stabilize someone there where they are able to speak with peers. They're able to have someone help them navigate through the next step.
Representative Priest for a question.
Thank you, Madam Chairman, and thank you, Ms. Fox. Are all of the regional crisis centers equal in the services that they provide? And say if someone from the North Country has a crisis that they cannot handle, do they then transfer him to like Manchester or Nashua where the service would be provided?
So that's a very good question. Our 10 community mental health centers have certain core services that they all are standardized and are embedded within our administrative rules. When it comes to the challenges that are faced, especially in the rural parts of our state, mobile crisis would be one really good example. We have had a differential response where we're able to have Northern Human Services covers those counties that are more remote and have much more travel time. And they also have 5 offices. And they have, so when we think of mobile crisis, you think of a unit and everybody's together and they're all together 24/7 in a van. That's not how it works. They're on call and they're deployed. And so they've strategically worked through that. But it continues to be a challenge. All right. And so I just following up on the regional crisis centers. So we have 2 that have been stood up. The most recent was in Plymouth by Lakes Region Mental Health, and Center for Life Management in Derry was the early adopter, and they are available. And these are not the full model. They're not 24/7 right now, and they're not the staffing model that you would see at the national best practices, but they are available and they are staffed. And so they were able to open. Okay. Page 21.
Madam Chair.
Representative Nelevenko for a question.
Yeah, a very quick question on when it says mobile dispatch and this is a crisis, that's a private one of your care providers in their own vehicle, or does it, does it interface with law enforcement? And how is this system, what does it look like in practice?
Yeah, so yes, yes, and yes. And what it looks like in practice is individualized. So it could be that law enforcement responds and determines that someone does not need to have law enforcement involvement. And so they will call and a team will be dispatched. The idea that it's a vehicle and a van driving around, that's not how it works. It's usually people on call, and then they respond from their homes or out of their offices if it's during the daytime. And so it could be, I know early on, it was really interesting because schools would call and they would have a youth who was having a mental health crisis, and maybe mom was working and unable to get to the school. So Mobile Crisis was able to go and help that student get through, and they never had to go anywhere else. They didn't have to hit an emergency room. So they're all very different in different situations. Some could be law enforcement involved, some could be school involved, and some could just be a family struggling and needing some help. And we have protocols and have worked out details when with 911, so we understand if a call goes to 911, what would be needed for a response versus a call going through 988 or through the crisis line.
Thank you.
Representative Priest for a question.
Thank you, Madam Chairman. On this, on page 21, this information is from July 22nd to December 24th, and it's very impressive of how many people you first get contacts with and the assessments that you do, and then the additional services that you provide to those who need them. Do you have anything that shows or compares this information to other areas in northern New England? No?
Yeah, I haven't seen it if it exists. So if there are other states that have a similar system and comparing our stats to theirs, I haven't seen that.
And again, this has just been created since January 22nd. Is that correct?
Yes. Yep,
Okay,
of
thank you.
22, yeah. All right. Slide 22. So again, this is just a further breakdown. We went all out on rapid response because we had data and we wanted to show you data. And so this is the breakdown for individuals to be who are 0 to 17. I'll bring my water up and when we take a break. So you can see the contacts, the unique numbers served. So you can see sometimes there are multiple contacts with the same person, and family, which we don't want to discourage. We think that's a good thing. And then how many dispatches have been requested.
Representative Wallner has a question.
So as I look at the three charts, it looks like about half of the contacts that come in to the original telephone call, I guess, end up being referred over. So what kind of skills, who is answering that phone and obviously being able to help divert people?
Yeah, so we have a contract for that. We have a call center. Carillon is our current contractor, and they are trained up on crisis response, and have backup as needed, and can tap expertise within their own organization as needed. And the deployments really, we are going to err on the side of caution. If someone says they want someone, we're going to respond. Does that answer your question fully?
Yeah, I just wondered, what sort of skills the people at the other end of the phone had.
Yeah, they're quite skilled in being able to do this screening and initial assessment, and we do spot checks to make sure that the staff are trained up.
Thank you.
Representative Seaworth for a question.
Thank you very much. I just want to make sure I understand what I'm looking at. The drop off from chart 1 to chart 2, part of that might be screening out the request on the phone. Some of that, as you said, is that the same individual or same family needs to contact multiple times. So it's one person served, but maybe 5 contacts. Is it mostly one or the other, or is it just a combination of everything?
I believe it's a combination. I would need to double check on that. Okay, so 22 and 23 are very similar. The 23 is 18 and older. And I believe if you look at this, you'll see that the number of dispatches for mobile response to the community are higher for children. And again, looking at that erring on the side of caution and the request. We try not to say you don't need us. We never say you don't need us. If there is a call for this, then we're going to respond. Many of the calls too are resolved through this contact and initial assessment, through either having the opportunity to talk through a situation and through a referral, and may not be deemed what you or I might call a crisis, but for that person at that moment is a need that's being met. And because we haven't hammered it home yet enough, we'll go to page 24. And this really looks at the 988 system and the number of calls that have been made, and really talking about the avoidance of having to go to an emergency department, which has been really the whole point of this whole system, is to avoid having families having to end up in an emergency room for a mental health crisis.
Representative Nelevenko for a question.
Yes, thank you, Madam Chair. This comes back, I think, with the question I asked earlier. So there are 988, I guess, suicide and crisis, but no, the breakdown of that is, the question I asked before was how many suicides and whether we track them. So the suicide and crisis is, there's no distinction. You don't have anything that breaks down how many of these are suicide and how many are you treating them all as potential suicide?
So I don't know as though that's a stat that we keep, whether it's a mental health crisis or it's identified specifically as I'm feeling suicidal. So I would have to check on that. But again, this is really just to be in a preventative way, to have a place for someone to call should they need and be in a mental health crisis, including if they are feeling like they're going to harm themselves. But the actual statistics about suicides are kept separately and not through this system.
Just a quick follow-up. The reason I'm asking the question is one of the metrics, if you've got a suicide prevention program, is, what's the number of suicides over time, and is that going down or is that increasing as a measure of the success of preventing suicides?
Absolutely. And I want to get that report to you.
Okay, thank you.
Okay. So we are now going to the Bureau of Mental Health Services, which is the adult population. So if we look at slide 26.
And we have Representative Priest for a question.
Yes, thank you, Madam Chairman. And Ms. Fox, again, just for a clarification, back on page 24, is this the total number that we're looking at of all of the age groups?
Yes.
Okay, thank you. From December of 21 to January 25, right?
Yes.
Okay, thank you.
Yep. December 24. Yep. December of 24. So, yeah. All right. So back to the budget. Which I think is what we're here for today. So we have the Bureau of Mental Health Services. It has the accounting units, as you can see here. The first one, the ProHealth New Hampshire grant, That grant has ended. While you see it in 24 and 25, it does not carry forth because the grant has ended. The Office of Consumer and Family Affairs, that's 100% general funds. And out of that, we fund, I'm just going to make sure, and I'm sure somebody behind me will jump up if I'm incorrect, but we do fund the staff that oversee our peer support agencies. And then for guardianship services, that is, we have contracts for guardianship services that there are with two agencies. And I think we'll talk about that when we talk about prioritized needs. Same with commitment costs. These are attorneys who represent individuals who have been subjected to an involuntary emergency admission. And so we have contracts with attorneys in that accounting unit. And then interim care funds are very, very small amount of funds that are used in unique circumstances where someone may need just one little bit of pot of money to be able to maintain tenure in the community. As we continue on slide 27, this is where we start getting into the bulk and the meat of the contracts and the funding and the services. So we have the community mental health program support. You'll see a lot of that is general funds. And when we talked about mobile crisis, that's where that is funded. We have the next one, which is peer support services, which are the peer support agencies that are across the state. We have contracts, I believe, with 8 organizations, and there are 10 locations, I believe, throughout the state. These are a regional approach, just like we have our community mental health services. Family Mutual Supports is a contract with NAMI New Hampshire, and they provide groups throughout the state and support families as they address their loved ones' mental health needs. The mental health block grant is the federally funded block grant for mental health from SAMHSA. And this has funding that goes towards our peer support agencies, so they have a mix of funds, our community mental health centers, and our crisis, when we talked about the set aside that's needed, the 5%, that is for the access point with the Carillon contract that I mentioned. The next account, mental health data collection, we disperse those funds to our community mental health centers, and we have a contract for our consumer satisfaction survey that's done with a contract as well. And I will stop there because I'm sure there are questions on these accounts.
Representative Priest for a question.
Thank you, Madam Chairman, and thank you, Ms. Fox, for taking my question. Back to page 26 on the commitment costs. You mentioned that you have contracts with attorneys as the need base. Where is that shown on page 105 at 10,005?
Sure. So in accounting unit 4115, you'll see that in class line 108, provider payments, legal services. And for the, compared to the current budget, we have essentially flatlined that at the same amount and rate.
Okay, I see it. Okay, thank you. Thank you.
Representative Wallner, followed by Representative Telersky.
Thank you. So on page 1006, I do notice that under the contract for the mental health centers, there is a considerable increase. And I know when you presented to us maybe a week or two ago, you mentioned that you were concerned about the mental health centers, some of them being fiscally in having problems. And I wondered, will this increase help shore them up and be sure that they can continue their work?
Sure. So I would like to point out that the what you will see within the Class 102 and Accounting Unit 4117 on page 1006 of the governor's operating budget, the $5 million that the department had requested in the prioritized need each year was indeed funded. And I can let Katya speak to that specific prioritized need.
Yeah, and we did talk about that, and I believe that you've heard from the Behavioral Health Association about that as well, about uncompensated care. As we've increased services and have access to these services, the community mental health centers not only have they experience with the Medicaid unwind, which is, I think you heard about from Director Lippman, that people who had qualified for Medicaid during the pandemic stayed on Medicaid and then were no longer eligible for Medicaid, or for some other reason were no longer covered by Medicaid. And so the community mental health centers continued to provide those services to those individuals. And so they had no compensation for that. As much as self-pay as they could get, they would get. The other thing is there are services that are paid for by Medicaid that are not paid for by commercial insurers. So somebody who is commercially insured may not have the ability to get something covered because it's just not a covered service. So functional support services is one of those services. So the community mental health centers continue to provide services that they're not compensated for. And we have seen a growth in that and an increase in their operating losses. And we had asked for a continuation of a one-time infusion of funds in this current biennium. And so we had asked to continue that $5 million in each fiscal year, and it was funded and recognized by the governor as a need to continue the community mental health center's work. I'll leave it at that. I think there were questions.
Representative Telersky, followed by Representative Stringham. Representative Telersky yields. Representative Stringham.
Yeah, so, we noticed that page 1007, that the budget was 24 million or actual expenditures. Is the reason why that's somewhat lower is because there's non-lapsing funds from the previous biennium, or are we really talking about a doubling of this area?
Sure. And I think this is one of the challenges with when you're looking at the governor's operating budget, because you're not looking at what was budgeted. It's a great question. So what was budgeted in the current state fiscal year was about $41.5 million. That particular class line does have a class note that allows for the appropriation to carry forward. What we experienced in the initial year was some billing delays. So those expenses will still occur, but they'll occur in state fiscal year 25 for some of the 24 services is what we're anticipating right now. So the overall, the largest increase that you're seeing there is that additional $5 million that was added. It is 100% general funds. And there is no available federal match for that.
Yeah, so this area overall, we're looking at 99% general funds. So,
Yes, that is correct. There's only a small amount of Medicaid admin that we're able to claim in this area, but it is primarily general funds.
thank you.
All right, let me get back on track here. So I think we're on page 28, which is really just an overview of the service system. So again, going from all the way from community education and awareness up to inpatient services with a lot in between. We have the Strong as Granite campaign. That's the one I referenced earlier. That was a universal approach to all populations, letting them know that help is available and there is strength in help seeking. And that campaign was pretty successful. I have the stats on that, but I don't think I have them with me about, the impressions, the advertising, the responses, visits to sites, to the site and things like that. But very, very successful campaign. We have first episode psychosis, which is a way to be able to identify after that first episode and get early intervention services to a person and their family. Peer support, we've talked about. There are 12 locations. I said 10 earlier, corrected by myself. So it's 12. And we have peer respite programs. So when we look at the housing continuum and the needs of individuals, they have small programs, 4 beds apiece. And they are able to have short stays. They're usually about a week, couple weeks. And it's for peers. And so this is added to our ability to address the needs of individuals who need just that break as they take from their community and take their next steps. Community-based services and supports, again, the Bedrock and the foundation are our community mental health centers. They provide a full array of services, including those that are listed here. We have 2 centers, as we talked about. There are federal grant opportunities, and there was the certified community behavioral health clinics. And so we've worked very closely with 3 mental health centers, 2 of which have since become these clinics. They're essentially enhanced community-based community mental health centers. So they have their community mental health centers plus, and that plus is the integrated approach with substance use services and the close connection with physical medical services. I see questions, so at least on the tip of the people's tongues, perhaps. Anybody?
I think we're all set.
Okay, great. So 2 have been certified. They started with their new payment methodology and being the full-blown CCBHCs, and that's in Manchester and Nashua, and West Central in Lebanon will be coming on board by July. The next is residential treatment and housing supports. We have a slide in here that shows the growth of the type of housing supports that we have. We have, again, the crisis services we talked about, and then we have inpatient services, which you'll hear more about when you have New Hampshire Hospital appear before you in talking about the designated receiving facility beds, of which there are 65 in locations other than New Hampshire Hospital. The most recent of which is Dartmouth Health has added 5 beds. And I think we're on page 29, and we start looking at some statistics again. The reason why we picked these numbers to go through June of 2024 is because we had 2 community mental health centers that converted to their EMRs to new software and new programs. So they haven't been able to produce the numbers, and anyone who sits on fiscal committee and sees the monthly dashboard knows that there has been a drop, and that's a result of those two centers unable to be able to produce those numbers. They're on it. They're looking at an April timeframe to be able to start populating from a financial standpoint and the data that's needed and how we capture it.
Representative Priest for a question.
Thank you, Madam Chairman. Back to, there's always a delay process with me, and I'm sorry about that. But on page 28, on the inpatient services, what is the vacancy rate for those beds?
That is a great question, and we're going to get a little bit into what the state has done so that there isn't a huge vacancy rate. I don't know the actual percentage, but I would say that it's probably on most days less than 10%.
Okay, thank you.
So on slide 29, again, showing and it's breaking it down between adults and children. And this really is looking at eligible children, so they're and adults. And when we talk about eligibility, it's a criteria that's established in law and rule, which talks about severe mental illness and what the criteria is for that. And so that's what makes someone eligible. So this doesn't address all individuals who are seeking services for mental health. It just is for those, it's depicting those who are eligible. All right, so page 30. I think we're doing well on time here. So we have more than 98% of adults served by the community mental health centers get their treatment in an outpatient community-based setting. So again, that's always our goal. We don't want people to have to hit a real high level of care. If it's needed, we want it to be available for those acute and unique circumstances, but we know that treatment in the community works and it's available, and that's where the need is and where we're meeting that need. All right, slide 31. So critical time intervention is a program that was supported by the legislature, and it looks, and so you can see the timeline of when it started and where it is today. This looks at, again, transitions. This is going back to what I said earlier about how those transitions in care are so important. And so it's why it's named critical time, that it's a point in time when someone who's leaving an acute setting and going into the community gets the care coordination and the help they need. And this is not a clinical service. It's really a service that looks at real basic needs and helping an individual navigate those needs and finding housing and finding the food bank and work and working with individuals. The reason why you see those numbers go up and down so wildly, first of all, the numbers are pretty small. Oh, I'm sorry. I was thinking of CTI. CTI is an area where we've had some staffing challenges. The community mental health centers have had staffing challenges. So if I were to present the data here, which is not here, you would see some ups and downs as the staffing has changed over time. But this is really about the readmissions. And this is a big data point that we look at. We look at 30, 60, 90, and 180-day readmissions. And this is something that we work with our managed care organizations. We look at for the critical time intervention program. And it's something that we hold ourselves accountable to, because once someone is discharged, we want them to be able to stay in the community. And how are we doing and how are we helping them do that?
Representative Priest for a question.
Thank you, Madam Chairman, and thank you, Ms. Fox, for taking my question. I'm very happy to see that you are addressing the need for recovery of your patients and making sure and to reduce their readmissions. Are you coordinating your programs with communities and private recovery houses that we are seeing now in all of our communities?
So coordination of services is so important. And when we say that, it's not just to a community mental health center, but it may be other types of services in a community. When we talk about recovery housing, I think it's tough because we, I immediately like, oh no, we're going to talk about that with our Bureau of Drug and Alcohol Services, and we're going to talk about that. But there is supportive housing in the mental health field as well. And so, we do have a process and we do have some oversight over recovery housing, which we'll talk about in a minute. Okay. So this is the housing inventory. We're pretty proud of this because we have been able to add to the inventory of supportive housing despite the housing crunch. And so we've been doing that in several different ways of how we've been able to do that, which I can talk about. But this just shows that growth in how many people we're able to support in housing units across the state.
Ms. Fox, we're approaching the noontime hour. And so I'm just curious as to your thoughts of a breaking point, and your thoughts for, it looks like we're about halfway through the presentation. So I'm anticipating probably another at least 2 hours more of presenting, unless you think differently, but your thoughts.
So I really want to talk a lot about Mission Zero because I know it's something that you've heard about. And so I worry that if we start that now, then it might be 1 o'clock before we finish. So it could be a good breaking point, but we're here for you and plan the day on it. So
Sounds good. Is everybody okay to break now for 1 hour? 1 hour. Okay, we
Okay,
will
great.
reconvene. We will
we can cut-
pause.
if we
Thank
can
you
make
both
it-
very much. Oh, Representative Stringham?
I was going to say, if we can make it shorter, that would be helpful for me, but I'm okay with an hour if everybody needs an hour.
Okay, a half an hour. Does that work for the committee? Can we compromise on 45 minutes? Is that all right? 45 minutes. Very good. So we will reconvene at 12:45. Thank you very much. Good afternoon, all. We'll reconvene this Division 3 of House Finance Committee work session on Thursday, February 27th, 2025. The topic is the Division of Behavioral Health. We've gone the whole morning since 10 a.m. through a packet that can be found online, and now we'll continue where we were, I think, on page 33, and we'll go from there. I do intend to ask members of the audience if they're interested in testifying after the presentation concludes, whatever time that may be. Okay, ready to begin? When you're ready.
Great, thank you, and good afternoon. So as we were talking about, we want to get a little bit into Mission Zero, which again, I think is something that people have heard about. What is Mission Zero? Our goal to have no one waiting in an emergency department in the state of New Hampshire for an inpatient bed for mental health services. And so I tried to hydrate over lunch, so we'll see if I can do a little better with my voice here. So for this particular graphic, you'll see that as part of Mission Zero, we had 6 key investments that we identified as needing to help us achieve that mission. And so the certified community behavioral health clinics, which I already talked about a little bit ago, the crisis stabilization centers, we talked about those as well. Care traffic control, that is something that you'll hear about more from New Hampshire Hospital. And that really goes to what we were talking about, the utilization of designated receiving facility beds. They are now able to know in real time what beds are occupied and which are available should someone present in an emergency department in the state, and be able to help coordinate that effort so that a person can get into that level of service in real time. So that's been really beneficial and helped us with that utilization so that we are closer to full utilization and not having beds go unused when somebody could needs one. We've had an expansion in the designated receiving facility beds. I mentioned the Dartmouth beds that have opened up, and as part of the HCA acquisition of Catholic Medical Center, there are going to be 10 additional beds that were part of that requirement through the Attorney General's approval of that acquisition. And so those will be additional DRF beds that will be coming online. We've had expansions in the care and step down in less restrictive settings. This is really addressing one of the drivers, which, as you can see on the right-hand side, we have the front door, the demand, we have the inpatient supply, the number of beds that are available, and then we have the back door. Where does someone go once they no longer need that acute level service? And so those supported housing that we've already talked about and shown the growth of the availability of supported housing, this is what number 5 is addressing. And then number 6 is a program that has been very successful. It is landlord incentives, and this allows someone to have a place that's available. It's coupled with a bridge subsidy, which is another program within the division. And it takes the supplemental funding that we provide to someone who is awaiting a federal voucher for what used to be known as Section 8 housing. It's a housing choice voucher. And now we take that and we incent landlords to rent to individuals who are transitioning from an inpatient setting. And we've had those transitions happen so that when someone is ready to be discharged from a DRF, they're able to discharge, and then that opens up that bed for someone who's in acute crisis. And so these 6 drivers have really made a huge difference and have allowed us to achieve mission zero in points of time. And we've been able to sustain a much lower wait list. And the time that it takes from someone who lands in an emergency department in an acute crisis to get to a designated receiving facility bed, of which, of course, New Hampshire Hospital has the largest number, that time has been reduced significantly. So we're really, really pleased with the work. Mission Zero remains something that we're always striving toward. So we can't say we're done, but we continue to see the results as we have expanded and enhanced and really focused on these 6 areas.
Representative Talerski for a question, followed by Representative Stringham.
Thank you. Congratulations on the department and getting this kind of progress and hitting that zero wait, which is excellent. I am concerned, though, with the potential changes to Medicaid. If we could talk about the number of people who are served that are on Medicaid, and if there is a reduction in people who actually have coverage, how that would affect Mission Zero and your ability to move people through the system.
So I think we're all concerned about changes in Medicaid. Medicaid underlies a lot of the services that are provided. From a programmatic standpoint, these are significant investments that have been made. And while we could take any one of them and look at general funds and then Medicaid funds, it really is intertwined and important, because in addition to these services, there are just the regular services, the services by the community mental health centers, the appointments, the ongoing assertive community treatment program. All of those could impact the population. And so we're closely monitoring that. I believe that you heard from Director Lippman. Every day we have new information or changed information, and we continue to monitor that very closely. But we know that anytime we have someone who no longer has access because of insurance coverage, whatever that is, it's a missed opportunity and it's worrisome.
Thank you.
A question about the MH supported housing inventory. Can you explain what support there is first in constructing and making the inventory available, and then what the ongoing costs are to the state and to the department to continue to have it be used?
Sure. There are different financial opportunities for the development of the housing. We have had one-time funds, the ARPA funds that I mentioned, that we use very strategically to build up our system, that were used for renovations for properties, and that either by our community mental health centers, or we also have partnered with NFI North, which has a number of settings across the state for what's known as transitional housing. And there also is the New Hampshire Housing Finance Authority has the Affordable Housing Fund that looks at projects such as those that provide for supportive housing across different populations. So as you may know, they have certain populations. So aging population is one that they have as a priority, as well as individuals with behavioral health conditions, including mental health and SUD. So that's for the actual capital costs. And then the ongoing costs are depending on the way that the program is structured would depend. So it could be that it's Medicaid reimbursable, or that it is something that's supported 100% general funds. And there are some of the supported housing has contributions by the individuals. So when I mentioned housing bridge subsidy, it really is a subsidy. It doesn't fully pay for rent, but it does it on a sliding fee scale.
Representative Priest, followed by Representative Nelevenko.
Thank you, Madam Chairman, and thank you, Ms. Fox, for taking my question. Again, as I look at the Bureau of Mental Health Services, which this and many other programs fall under, it looks like it's all federal funded. Is that correct? I'm looking on page 109. 009. Maybe it's more to it.
Sure. That specific accounting unit, that's the mental health block grant, and that's 100% federal funds in that specific accounting unit.
Yeah, I see on page 110 that you have general funds too at 56.
Yes.
Okay, thank you for that clarification. Thank you.
And I think another important thing, we are talking about Mission Zero here within the Division for Behavioral Health, but there's elements of this that are also involved with New Hampshire Hospital as well. Their staff play a role in the care traffic control coordination, and I know when Ellen Lapointe, the CEO of New Hampshire Hospital, will be here, she'll be talking about that as well. And so this isn't just an initiative isolated to the Division for Behavioral Health. There's a lot of other actors and players and other dollars involved in other areas of the department, just because it's been such a wide-ranging strategic effort.
So any funding effect on this from the federal government or from the general fund would have consequences throughout your department?
There could be consequences, yes, if there's a reduction in funding towards this
Okay.
larger initiative, yes.
Thank you.
Thank you, Madam Chair. I've kind of a high-level question here. This is on page 33 is a 10-year representation of a 10-year plan. And if I were looking at this from a budgeting and planning standpoint, so my first question would be, where we stand right now, point in time, and if I were to look at this as a pie chart, what portion of the resources is allocated to each one of these 6 different areas? And then what's the expectation over time as to how that model would shift resources? I mean, I know that's it's a 30,000 foot level, and maybe you haven't looked at it that way, but
Yep.
I think at some point you would expect, if you're successful in some of these areas, you would see from a planning standpoint and a budgetary standpoint, a shift in the resource allocation.
Great question, and I'm glad you brought up the 10-year plan, which I should have, in my initial comments, talked about that. So the 10-year plan was established in 2019, and it had front-loaded a lot of the recommendations, some of which are you'll see the results of those recommendations are in the programs that have been stood up and exist today, including mobile crisis and expanded housing opportunities. We had some significant Medicaid rate increases that were part of that plan. Mission Zero is a subpart of that plan, which is much more wide ranging and not specifically just to address emergency room boarding, which this is. When we look, we could identify how much funds go to each of these. What's important to know is that if you take any one of these away, we would expect that we may backtrack on that Mission Zero. So these are ongoing services that we believe need to be supported. We do know that the more that we're able to build up these services, the less reliance we're going to have on the higher level of care in a designated receiving facility such as New Hampshire Hospital. So we're trying to decrease demand for that while increasing those community supports. And this has been successful. And I thank Representative Chlursky for congratulating the department, but really it's congratulating all of the community providers who've stood up these services and have every day worked with us to address this need. So I'm not sure if I answered your question, but be happy to clarify.
Not directly, but I'll leave it for now.
Okay. You can say it. We're just trying to make sure that we address that. As far as, if you were to look at this as a pie chart, would we move things around? I think so. I think we wouldn't need to continue to expand DRF beds, that we could move some of those resources into the housing supports, for example. That would be one that we could see. So.
Yeah, what I was looking at is really, if you're successful,
Yeah.
just looking
Yeah.
at this, over the time span that you're talking about, the metrics for success on this would suggest that you'd see a shift you'd see savings, you'd see budgetary implications in each one of these areas, and you'd see if you were successful in what your goals and objectives are. But that's, as I say, I'm prepared to leave that for now.
I think when thinking about savings, one important thing is to sort of understand, where the 10-year mental health plan came from as far as litigation, other active litigation against the state where we are not satisfying all of the needs out there. So when just thinking of it, in simple operating terms, while you may assume that there's some savings, there's also some other factors behind the scenes that exist, basically. So it's not necessarily if you invest now, then you can save later. It's part of it's looking at what was occurring prior to doing these things, such as individuals waiting for care in ER boarding, and where we've been able to get that number down significantly. That's not an area where you can necessarily go back, because if you go back, you're probably going to end up in the same spot you were in.
Thank you.
Representative Priest.
Thank you, Madam Chairman. Again, on page 33, do you have, you mentioned the success, and again, as with my fellow representative, I do congratulate you on these key investments and what you are doing. Do you have any numbers that kind of
Yes.
show this? And I would like to see them, and how far back do they go?
Yeah, so as Nathan mentioned, you're going to be hearing from New Hampshire Hospital. We actually publish a dashboard that is live and public facing that we can get you the link to, where you're able to see that data. So we look at the completion of a submission of a involuntary emergency admission paperwork, and how long it takes from that completed IEA form to be submitted to our care traffic control, to how long it takes to locate a DRF that can accept that person. And so we have all of those metrics. You can see the whole thing on the wait times, the wait list, and how that has changed over time. So we'll be happy to share that with you. it's interesting because I've been watching your sessions, and so I pick up on things that you're asking that are going to be for me. And now I'm doing exactly the same thing. Oh, wait until you hear from this part of the department, not me, but from them. So it's interesting how the can gets kicked, but we want to make sure that as a department we're answering all of your questions. So bear with us as we go through this, because you will get your questions answered. It just might not be by me today. All right, slide 34. I'm going to actually skip some of this because we already talked about it, but it's the more detail about the CCBHC clinics and what they are, and how they are different from CMHCs, but are in how they are being stood up. One thing of note, you're going to be talking about HB2, I assume, at some point in time at the end of HB1, going through all these presentations. And we have the language that I know that you talked about, I believe, Nathan, so that I could explain it, where it talks about wait lists and it talks about suspending a particular state law, and that has been the prospective appeal of the suspension of that law. It gets very confusing, but that does, what the current footnote does, is it allows the community mental health centers to develop a wait list based on funding availability, because otherwise state law indicates that they have to accept anybody who is seeking services regardless of their ability to pay. So that has been suspended, so they have been able to maintain that wait list and help stem some of their operating losses. With the CCBHC model, in order to qualify for the federal demonstration, they do not have that luxury. So they are, we're closely monitoring, knowing this just went live on January 1st, if they're seeing an even more increased demand that is uncompensated. So we're going to be following that.
And for general context and orientation, it's on page 48 of the draft HB2 that you have, and it's entitled, this section doesn't have a number, but it's entitled Prospective Repeal Regarding Eligibility for Services Extended, and it's followed by amend 2011-2096 and so forth. But effectively what you're seeing in House Bill 2 is, as Katya was saying, the effective date of the original HB 191 from 2011 is being extended out to July 1st of 2027.
And the reason why I raise it here again is that the CCBHCs will not be able to take advantage of that because of the federal demonstration, the requirement by CMS that they accept all of those who come to their doors for services. So that's where the uncompensated care discussion of that $5 million of prioritized need comes into play. So I'm gonna skip through this. If you have questions about CCBHC, please let me know and stop me. I think we'll go to slide 37, if that's okay. So this is to improve access for services. And this is very specific to those who are on Medicaid, but you don't open up a service based like a community mental health center doesn't say, okay, you're Medicaid and you're XYZ. They're going to evaluate the patient's needs. So that's what this is looking at. While it's a Medicaid demonstration, it does require us to serve everybody who comes through the doors. There's a certification process. We received as a department a federal grant so that we could set up that certification process. And that is what Manchester and Nashua achieved. And that's what West Central Behavioral Health is going through right now. And the idea is that people have access and there'll be high quality services and it will focus on that care coordination. And that we should see as part of Mission Zero and as part of this demonstration, a decreased demand for acute level services. And slide 38, strong as granite. This is some of the media that we use as part of that campaign. Suicide prevention, we've talked about that. We are going to get that report to you. And this is part of that, which is the 988 and ways to address that prevention effort. And I will pause there and then go on.
Do you,
Representative Daniels for question.
thank you. Do you coordinate with the VA at all?
We do. So the VA has a special response and a team of call center staff who are specifically well versed in veterans matters. And so, yes, we very much do. And they are part of our 988 steering committee and our subgroups. So, yes.
Do your statistics on suicide prevention include the VA?
Yes, yes. So we can actually break out from 988 how many people who've accessed those services have gone through the specialized veteran line. So yes, it is a population that we pay special attention to. All right. So I think we have 2 more bureaus to go. So halfway. Bureau of Homeless Services. So the Bureau of Homeless Services joined us about 3 years ago, I believe, with a recognition that many of the issues are that homelessness is a factor with mental health and substance misuse conditions and vice versa. And so we wanted to fold in homeless services into our division and to address those needs. The accounting units. So we're looking at the PATH grant. This is a grant, and we'll get a little bit more into this, but this is, we contract with 4 community mental health centers to provide these services. The next accounting unit is the housing and shelter program. This houses our contracts for state grants in aid, which is all of the homeless shelters that we fund across the state. And we'll talk about that, but under prioritized needs, this was under Senate Bill 406 last session. We received $2.5 million to increase the rates for shelters, and we were able to do that. And in the governor's budget, it is funded to continue those rates at that level. So that prioritized need was submitted and picked up and is in the budget that you're looking at. Also in this account are our federal funds from Housing and Urban Development and our Emergency Solutions Grant. Again, I'll go into these programs, but those are funded out of this account.
Representative Telersky for a question.
Hi, thank you. On page 1012, can we look at, I think it's line 102, and discuss the bill that this division has been looking at regarding the Waypoint Youth Shelter Services? There's been some confusion of people saying it's included in the budget, it's not included in the budget. And if it is in the budget, do we need to specify it's going to Waypoint?
So it's in the budget. It is in that budget line. It's in 102, as are those that prioritize needs for the shelter program. So yes, the $500,000 per year is in this budget.
I have another question. If I remember correctly, it was also in last year's budget, but they didn't receive the funds, which is why we had this bill filed.
They they did receive the funds that were part of. I'm trying to think of where they came in, but they were part of an allocation that was made. And this just continues that funding. So the bill, at the same time we put it in as a prioritized need, there was also the separate bill to fund them. Same dollar amounts, which is why I think you've seen and heard some different things. But right now, the $500,000 that we had previously funded them at, that they're currently under contract to receive, is continued through this budget as it is today.
Okay, so you're saying we don't need to specify anything in HB1 that determines the money goes to Waypoint Young Adult Shelter?
There'd be nothing prohibiting you from putting a class note in there saying of the $500,000 budget in each year of the biennium, 500,000 shall go to Waypoint for the purposes of providing youth shelter.
I guess I'm just trying to get back to the original discussion from maybe 2 months ago when that bill was filed to, oh, I am so glad the door just opened. Representative Wallner, we're discussing shelter and Waypoint on page 41 of our PowerPoint. Not to put you on the spot, but to bring you up to speed, the Waypoint $500,000 a year funding is included in HB1, which I think we're all thrilled to find out. We're just discussing if we feel that there needs to be an amendment for a class note that specifies the allocation to Waypoint. So I don't know if you would have any questions to dig into that.
I think it's something we should discuss about really noting in the budget that it is for Waypoint, or, I don't know. Okay,
Sure. Yeah, and this was a prioritized need of the department for this biennium. So there is that record, but we've certainly had instances in the current biennium where something as Representative Telereski is suggesting, where it clearly specifies that that money is intended for this purpose with this provider. So.
okay, great, thank you.
Representative Nelevenko for a question.
Yeah, I'm confused. So that means we don't need the bill that was filed for that?
That's what sorry. That's what we're trying to determine.
So if it's included in the budget, and if we somehow get a note in, some kind of a note in there that says it's specifically in the budget for that purpose, then that would make the bill moot.
Right. So we'll probably discuss it at a future date when we're digging into doing amendments. But it's my understanding it was the specifying that this amount is supposed to go to this particular service was the question. So I'm sure we'll talk about it down the road.
Yeah, we just want to make sure we're not double.
It won't be
dipping.
double, I assure you.
So it sounds like this note that's referred to would amend the bill, would replace it essentially in order to make clear where the money is allocated in the budget, or would it add to it?
It would depend. So if you ITL'd the other bill and you added a class note directly in the department to use those funds in whatever specified amount, the 500,000, then the bill wouldn't be needed. But I'll defer to the committee on that.
Okay. Representative Waldner on this topic, and then Representative Priest.
Yes, on this topic. So I think the practice at the Finance Committee in the past on situations like this where there was a bill and then there was an appropriation in the budget, usually we have retained the bill That means the bill doesn't go forth. It just stays right here in the Finance Committee. And then the budget, we roll the amount into the budget. We retain the bill. Once the budget is completed in June, we would still have the bill as retained, but we would report it out next year as inexpedient to legislate. So that we haven't given up the bill to find out, I mean, if the Finance Committee leaves it in the budget and we send it over to the Senate and they take it out, then we might lose it. As long as we're still in possession of the bill, we might be able to do something with it in the next year.
Okay, thanks for the clarification for a newcomer to the whole process here.
Thank you.
Representative Priest for question.
I want to thank Representative Wallers for coming in and explaining that. That was my question about that retention would be the best option at this time instead of ITLing it. But I did have another question regarding on page 1013, no, I'm sorry, on 1011, when it talks about the funding for this division, it shows that you are getting $5 million from a federal source, and then you're going to be transferring that $5 million. I'm sorry, it's on page 1012. Estimated source of funding. Transfer from other agencies, and then you'll be taking it away. Can you explain that for me, please?
Sure. So the transfer from other agency line, what that represents is that represents a $5 million transfer from the opioid abatement trust fund.
Okay.
And that is located, there's a corresponding provision on page 47 of the draft HB2 document that you have that provides for that for that transfer there.
Okay.
And those dollars are being moved to support the SGI, the shelter contracts, as there's a correlation between opioid use disorder or risk of opioid use disorder for members of that population, and that was added during the governor's phase, and the general fund portion of that was reduced from the agency to the governor's phase there.
Okay, so then you have less funds for budgeted revenue transfers, and it looks like you've taken the $5 million out again. And I'm confused about that. Can you clarify that?
So that
You put it in and you take it out.
Sure. So that's being removed so that it's not counted twice in the budget, because those dollars should show up somewhere else within the budget.
Okay, I see.
Traditionally, this is a unique case because the opioid abatement trust fund is not included in the budget. But when I had conversations with the Department of Administrative Services, they verified that it should be showing up that way.
Okay, thank you.
Representative Nalavenko for question.
Quick question on the page 41, where we're looking at the housing and shelter program, and it says 20% other funds. Is that what we were just talking about here with the 5 million? Oh, okay, that's what I thought it was. Thank you.
Representative Seaworth.
Thank you very much. I'd like to look back up the lines 72, 74, 102 with the asterisk. It looks like there's been some movement between lines, and I'm trying to understand what stayed the same and what's different there.
So if you look at class 103, class 102, you see 4.9 million adjusted authorized. And then when you scroll over, you see 7.9 next to that. SB 406 appropriated $2.5 million of general funds. And when we prepare our budget, we do the reconciliation, the history for the adjusted authorized in August. And I don't believe the legislation either, there was a delay in signature, it doesn't always take effect July 1. And then there's also a process after that where we go to the Department of Administrative Services with a memo to accept those dollars into our budget. So the $2.5 million is not being recognized there. What's also not being recognized there is the $500,000 that was added for the youth shelter program that we were just discussing. And let me see here. And then there's okay. And I would have to dig into, let's see here. And then there's also some movement from class 74. So class 74, I'm going to go into it's kind of an esoteric subject, but it's important for this committee to understand. When we receive federal dollars, we have to make a determination when we enter into an agreement as to whether it should be considered a subrecipient or a contractor. Simplistically, a subrecipient provides services on behalf of the department. And under 2 CFR 200-331, there's certain criteria that are used to make a determination on that. And we need to track that appropriately. And so we use different class lines within the budget to make sure that if it's federal funds and they're a subrecipient, we need to track those in a certain class line versus a contractor. A contractor is a scenario where they provide services to the department. So that may be like they're building a website for us, they're maintaining a system for us. That's the simplistic way to think about those two determinations. So I know that there is some movement between those lines for that purpose to reconcile some of that as well. But if you'd want a more detailed history or crosswalk, I mean, we can do that as well, similar to what we discussed yesterday on another topic.
Thank you. Mostly I wanted the high-level explanation that you gave, and thank you. I don't know, other members may be interested in the details.
Yeah, I just think it would be helpful to, if that's included in the crosswalk exercise that we're doing, to kind of help clarify what's moving where.
Sure, we can do one for this accounting unit as well. That's easy.
Representative Priest.
Thank you, Madam Chairman. My question was aligned with my fellow representatives, so it's been answered. Thank you.
All set.
Okay.
Oh, Representative Telersky.
Sort of circling back to SB 406 and the increased rates for daily rates for the beds. I believe we increased it to $27 a day. I don't expect you to have hard numbers, but any idea on the impact of that and if it was helpful to the providers? Knowing it's probably still short.
Yes and yes.
Yeah, okay.
The impact was great. As we heard, just the increased costs that they have for everything, like we've all experienced with electricity and food and all of that, that helped offset some of those costs as well as staffing. And they talked about the need for maintaining staff and how they could use those funds to do that. So yes, it did have a good impact. I'm sure that they could use more because I think that $27 a day is still lower than what they expend. And they do significant fundraising for the remaining of those funds and other grants that they get from the community. But it did make a difference, and it made a difference enough that that's why we asked for the prioritized need. And most importantly, why the governor recognized that it was really important to maintain that rate.
That's good to hear. Do you have any thoughts about people who aren't being served? and any even anecdotal stories in general areas of people who can't be served because there's no openings.
I would defer to the providers to be able to talk about these circumstances under which someone is not able to receive the services and be able to have a bed, so to speak, because they're going to be on the front line and be able to have that. And I think that continuing these rates is a way to ensure that the beds that we do fund, 934 of them, are available and that we don't lose ground.
Thank you.
Representative Priest.
Thank you, Madam Chairman, and thank you, Ms. Fox. Question, you mentioned something about you're receiving HUD funds. Is that on the budget? You mentioned $5 million or something? You wish.
So I didn't cite a number, and we do receive HUD funding for our blanking on the community of care, the COC funds, continuum of care funds from HUD, and we receive some other funding. I don't know if Nathan could specify where it is and it shows up in the budget book, but we're going to talk a little bit more about that as we go through the Bureau.
Sure, it's on page 1012.
Okay.
The federal funds line there is the continuum of care and ESG dollars there.
So that would include Medicaid and HUD funding? Is there any other federal funding in that?
There's no Medicaid dollars there.
No Medicaid?
No.
Oh. Okay. So that 11 million is all HUD? Is that what you're saying?
Does our SAMHSA funds show up there?
I believe that there's a small
Path,
portion of
yeah.
other federal funds, but the vast majority of it is HUD funding. This particular contract has, I don't know off the top of my head, but probably north of 30 or 40 different contracts that are funded out of this, and some of those are coming through HUD for the continuum of care. And those, there's some small grant dollars. There's also some HOPWA dollars in there as well that have very specific requirements, and they're on different time frames and grant periods. And you'll see those go through GNC 2-3 times a year, depending on how many updates we have to those awards.
Okay, thank you very much for the clarification.
All right. On slide 42, the unnumbered page, really talking about the service system. We're looking at community education and awareness. The entry point for homeless services is 211. And so people are able to access housing and homeless services through that. And then we have the continuum of care that supports a coordinated entry system. And we have what many of you are aware of is the point in time homeless count that we do on a particular day in January. And we use those numbers to establish funding throughout the state for our shelter program. So it's a very important count that many people are involved in at the community and regional level. We have prevention and early intervention, so housing stabilization, which provides short-term rental assistance and supportive services. I can
Representative
see you're about to ask a question.
Nelevenko.
Just as a, a point of interest, point in time, how is that conducted?
That's a very good question. So all of the shelters and our outreach workers are asked to participate, and they report out on how many people are in their shelters. And then we have the outreach that looks at unhoused individuals as well. People who aren't in any shelter. Who
Yeah,
are,
so for example, I know in the Keene area, there's some, encampments
Yeah.
and that sort of thing. So how are you,
so they're
how are
all
you picking those numbers up?
it is amazing how our communities know who and the rapport that they have with those individuals. So they're able to go out and have those and account for individuals who aren't in a homeless shelter.
Thank you.
Okay. And community-based services and support. So we talked about emergency shelter. The PATH workers in the community mental health centers, they're the ones who are going out. We have 4 centers that have that specific specialization with those workers. And then that's funded, as we said, in the PATH grant that you saw in the accounting unit. The Continuum of Care funded projects. So they provide permanent supported housing, rapid rehousing, which is we get somebody quickly into housing and keep them in housing. We have youth transitional housing, and that was a specific grant. And then we have the Homeless Management Information System. That's our data platform, and that all of our contracted providers submit data to us so that we are able to break down, age demographics and gender, and really see what's happening in that in the homeless system. And then we have, again, homeless prevention. We'll go more into this, and that street outreach. Right, so we are at page 43. This goes more into point in time and how that is counted. And we do go through a period of time. Everyone starts calling us in February asking what the count was for this year. We do go through a cleaning of the data to make sure that we're not duplicating data and that we're unduplicating it. So it takes a little bit for us to actually have that count. And we do use that count in formulas for how we're going to allocate funds to our shelter programs and our winter emergency sheltering.
Representative Telersky for a question.
Can you explain to me? I understand people who are sheltered, you have to have a bed to be sheltered, right? So the drop from 2023 to 24, that wasn't necessarily a drop in beds available. It was a drop in persons utilizing those beds, correct? Or am I wrong?
No, I think I understand your question, and I think you're correct. Yes.
Okay. Okay.
Representative Priest for a question.
Thank you, Madam Chairman. On that same chart on 43, can you explain why there was this sharp rise in 2023 followed by 2024?
Sure. So we had the housing program that was through the federal government that provided the funding for, I forget what the name of the program was, so I'm sure people are shouting behind me and I'm going to get all kinds of messages. But there was the housing program that was run through the CAP agencies.
Okay.
That then that program wound down. So that is where we did not have, so we had people that were counted as sheltered that became unsheltered in the next count. And so that was rentals and hotels and different types of solutions that were made.
Okay, thank you very much.
Representative Stringham for a question.
Since these counts are done in odd years and in January, has the 2025 census been completed? And
Yes.
is it available?
Yes, and as I said, it usually takes us a few months to clean the data and to get it unduplicated. And so we will get preliminary numbers soon in the next, probably by April. They're not usually published until later in the year, but we start sharing what those numbers are, the unofficial numbers, as soon as we feel comfortable being able to. So I don't have that information for you today, unfortunately.
Yeah, I don't know if you've glanced at it, but it, you know, preliminarily unofficial, not finished, is there anything in there that you think might be valuable to those of us on Finance Committee?
I literally have not seen any numbers, so I don't know, and I haven't heard even reports. So I don't have information to share with you today. Probably before the budget wraps up, then we'll have that number.
Okay.
All right, so page 44. So this is the homelessness prevention, and this is a way to catch people before they lose their housing. And so there's rental assistance and supportive services. The idea is if you keep somebody housed, then they can go on and have that more self-sufficiency. Whereas if they lose housing, it is so hard for them to gain it back in any way, shape, or form. So we have these projects, and you can see the numbers that have been served by that. And you can see the age demographics, and that ties back to that really important data management system that we have. So that's how we're able to share this information with you. And then we have the exits from this program to permanent housing, which is at a very high rate. Page 45. So we continue to talk about the prevention and these, oh, I'm sorry. This is the duplication that I was talking about. Pages 44 and 45 are the same exact.
And in the meantime, we have a question by Representative Priest.
Great.
Thank you, Madam Chairman, and thank you for taking my question. How do you eliminate the duplication on your homeless numbers from the state and versus the local? Because a person may be facing homeless, he goes to his welfare officer of the community, and we don't, is that coordinated?
Yeah, so it's a coordinated approach. The state doesn't do the count, the communities do the count. So that's another way to have that quality assurance. But to the actual matching and determinations of unduplicated, I would need to check with my staff to see how they do that. But it's a pretty rigorous process because you don't want to overstate or understate the status of the population.
Representative Wallner for a question.
Thank you. So I noticed on page 44 that you have it broken down by age for the homeless prevention. But I wondered if on the point of time count, do you count children? Do you have a
Yes.
count of how many children, how many adults?
Yes.
You do?
And families, yes.
Thank you.
Representative Tulersky for a question.
How do you handle situations where a homeless family may be living in a hotel or a motel or with family couch surfing kind of thing? How do you even do that?
We do, and we do it through the service providers. So if they're known to the community, it may be, as mentioned, town welfare may have helped support somebody in a hotel. There's couch surfing that goes on. And again, we rely on our service providers, our communities, our any touch point along the way to help us identify that.
Thanks.
Schools are included as well.
Oh, good. Okay.
Representative Priest for a question.
As a continuation from the question raised by the representative before me, this also includes nonprofits, agencies like Family Promise in Concord.
Yep,
Okay, great, thank you.
absolutely. Yes. Churches are a great source of information. All right, 47. I think that's where I am, right? Oh, I'm sorry. We're on 46, right? Yeah, 46.
I think
So-
it just started 46.
Okay, all right. So emergency shelters, we've been talking a lot about that. We do differentiate with chronically homelessness, which is the length of time that someone has been homeless. We look at families and we look at veterans as well. So we do break down that data so that we know. That is a big effort that has been made across the state. Most notably, Nashua and Manchester have taken steps to really reach out to that population, and it has made a difference in keeping those numbers low. And obviously, we want them to be zero, but there has been significant promise in those communities that have focused on that population. All right, 47.
Representative Priest for a question.
Yes, back on 46, when you mention unique households, what do you mean by unique?
Unique means unduplicated, so individual. All right. So the path workers, this is the individuals who are at the community mental health centers, and this shows their statistics and how referrals are made, the program enrollment, the demographics, and anything else about that program is included here. And when they received and attained that housing. All right, are we ready to move on to the Bureau of Drug and Alcohol Services, our last bureau?
Ready to move on.
Okay. So we'll go to the accounting units on page 49. The program operations, there are no contracts that are associated with that. That's for staffing. The block grant, oh, I'm sorry. I'm supposed to give the page number. So 992 is where that starts, if you want to orient yourself to that. The block grant, so SAMHSA has two different block grants. They have the one for substance misuse, and they have the one for mental health services. You're now seeing the one that is for this program area. And we have multiple contracts that are funded through this. And I have this list of 21 pages worth of contracts and can dig that up if you have specific questions about where the funding goes for that. Same thing with prevention services. That's general funds. Keeping in mind with our block grant funds that we have to have a maintenance of effort. So when you see that there are general funds that are expended, those are very important to help support our federal funds and maintain that level. We are able to claim what we spend in general funds on Medicaid as part of our maintenance of effort, which has been helpful in maintaining the 2 years of keeping the same level of general funds that are spent over that 2-year period to match the significant federal dollars.
Representative Nalavanko for question.
Yes, thank you, Madam Chair. This is a general question on contracts. And are these typically multi-year contracts or one-year contracts with a renewal clause in them? And I suppose there's some performance metrics attached to the contract, so maybe just take a couple of minutes to describe the whole universe of contracts.
Absolutely. So there are different ways. Everything you mentioned is a potential. So we do have 1-year contracts depending on the funding source and the expectation of what we're buying with that contract. More likely, for example, we have treatment contracts. So those are your contracts that when someone has either inpatient treatment or outpatient treatment and they contract with the state and with this division, those are more likely to be multi-year so that we typically align and do renewal options with our state funding. So with your budget, with a 2-year budget, we look and we know that we can put those funds into contract, and then we have renewal options that can be adjusted based on the level of funds that we have. We know the burden that is placed on our providers from having to contract and what that process is like. It's pretty intense. And so we try to have, especially with contractors that we know have good performance outcomes and meet our metrics and meet their obligations under the contract. We try to stretch it out beyond 2 years, but it really depends on what the contract is for and for how long and what funding source.
Okay, thank you.
And oversight, when we're talking about staffing in any one of these areas, that really is how we oversee with the staff is they have contracts. So we have in BDAS specifically, we have units and they oversee those contracts. So there is a clinical unit that oversees the treatment contracts. There's a prevention unit that oversees the prevention contracts. So we have it so that people really can be specialized in knowing their contracts and being responsible for that. So if I have a question about a contract, I know who to call because that's their contract that they're overseeing and managing.
Thank you.
Representative Seaworth for a question.
Thank you very much. When I look at, let me make sure I'm in the right line. Yeah, it's 3380, and that has the 4 individuals overseeing those contracts. It looks to me like the governor's budget reduced that to 1, or is it moved?
No, so it's moved. So if you look at page 994 within the 3168 SAPT block grant account, you'll see 10 positions, 10 permanent classified positions there. So 4 of them came from accounting unit 3384, 3 of them came from accounting unit 3380, and then 3 of them came from accounting unit 2070. So we were moving and consolidating those positions into a single accounting unit here that's 100% federal funds.
And because I was figuring out where I was, the first accounting unit that the 4 were moved from was
3384,
3384.
Yep.
Thank you.
of course.
Representative Navalenko
Just
for question.
Naladenko. Yeah, just a quick follow-up to Brian's question, Representative Seaworth. That'll be in this crosswalk exercise that you're doing, so that we can,
We can prepare one for this as well.
yeah, because it's, I think it'll make it much easier for everybody to be able to track all of the interdepartmental movements on these funds So we'd appreciate that.
Yeah, sure, sure. We can prepare one specific to this as well. We don't plan on preparing one for the entire budget, but if there's specific areas that you're interested in, please let me know. And I think one kind of important thing, I always try to put myself in your shoes and just sort of like imagine like how hard it is to look at this thing and be like, oh, what's going on here? During the year, we make in February of every even numbered year, we have an opportunity to kind of review the way that we are accounting for things, and we do try to make changes. And it's quite intentional. It may be for operational needs. It may be to isolate specific funding sources to make it a little easier to track. Sometimes it's auditor suggestion because they don't like the way we may mix general and federal funds in the same account. Kind of depends. So there's a lot of reasons for why we do those things. I just want to make it clear that like we're not trying to make it harder to follow or anything like that. And we'll prepare whatever you need so you can kind of follow the bouncing ball.
Yeah, I think it was the other day I said, I like apples, I like oranges, but I hate fruit salad.
Representative Priest for a question.
Thank you, Madam Chairman, and thank you for taking my question. Back to the alcoholic and substance abuse program. The numbers of the clients that are requesting services are alarming. And we talked about this briefly, but what in the budget do you have for recovery houses to make sure that the patients that come out of treatment don't go back on the streets again and have to repeat this again and again, and they're safe for a while until they can get their act together?
So I can take that now, or when we go into in the next couple of slides. But I know that this is an area of your interest in. So we have recovery housing. There are different types of recovery housing, and I can explain some of it. Some right now, and some of it is respite. Some of it for somebody. So under the state opioid response grant, which you will see on the next slide, which is under the accounting unit 7040, we have we had the opportunity to fund a couple of programs where there is respite for someone who calls 211 or goes through a doorway and is needing treatment but can't get into treatment for a couple days, perhaps because they have to get all their paperwork in place, or they need to settle matters and get admitted. And during that time, they can go into respite. So that's one way that we help as people are awaiting that transition into treatment. For recovery housing, we have different programs. We have a certifying body which certifies recovery housing. And in order for them, a recovery house to get a referral from the state and from the doorway, they need to have gone through that certification process. So we oversee that, and that provides standards by which these recovery houses have to abide by in order to be referred, get referrals, so that people can use state dollars to be in that housing. There are so many different types of recovery housing across the state. There are private entities. I think many of you have them in your communities or have heard about them in your districts. And they're all different models. One of the other aspects of recovery housing, any that is state funded, must be able to have individuals who may be using medication for addiction treatment. They have to allow that. So if there is a philosophy that people should be abstinent only, including medications for addiction treatment, then we're not going to be able to support them in those funds. And I'll stop there.
Thank you.
Representative Telersky for a question.
Thank you. I'm looking at the prevention services 3380. I don't know if we've quite gotten there in your line, but we're sort of talking about this. The bottom of the budget, page 995, there is organization notes with 4 different organizations. I was involved with getting that in here last biennium. So I'm a little confused by the asterisk on line 074 and the fact that the note refers to class 102. So can you just explain if the funds from last biennium made it into this year's budget or not? Thanks.
The short answer is yes.
Okay.
Yes, they did make it in. So this carries that forward, and the governor included it in her budget.
There, I want to verify this, but I do believe that there is one subtle change
It's the 5 verses.
in the current biennium. There were 5 organizations that were identified in the original legislation, and it was $40,000 each year for each of those organizations. And in the current governor's recommended budget, there are 4 organizations listed. When following the passage of Chapter 106 laws of 2023, one of the organizations chose not to accept the dollars, and so that's been accounted for in the current biennium.
Interesting.
Representative Stringham for a question.
Yeah, so I'll jump around to 3382, the Governor's Commission. In the briefing book, it talks about the number being served, or the caseload is 44,000 in the current biennium, and that jumps to 60,000 in the budget that we're working on, with essentially no change in authorization. Are we finding that there's less intensive services that are still just as effective for the people, or was there tremendous unmet need, or what's driving this change?
Thank you for the question. I'll bring that back to see the change. It could be in what was funded and how many people the reach is in that particular area. Sure.
Sure. One important thing about this accounting unit for the governor's commission funds is the agency income. This represents 5% of the gross profits of the liquor commission, and that went into being last biennium. And so these are estimated revenue amounts included there based on the estimates that came from the Liquor Commission. So the funding here is not necessarily what might be the need, but it's what's projected, and that's specified in state law.
Can I ask a question?
So I guess the question I have, if the annual cost per case is $250 under the current biennium, and the projected is to decrease to 178 in the next biennium, is that really realistically enough money for those services to be provided, or are we providing different services that are less expensive? So
I think it has to do with the types of services that were funded under the governor's commission. So if they change their funding from serving 100 people, and then they choose an initiative that serves 1,000 people, you're going to see that difference. But let me take that back. These are, as Nathan said, these are estimates. And so it may be that we don't end up serving 60,000. It may be closer to the 44. And really, when we talk about prevention services, those are really estimated when we talk about the reach of a particular program when it's to a broad audience.
Representative Telersky for a question.
Thank you. It's my understanding that a few days ago, another division was looking into and discussing the liquor fund and where the money goes. Would you speak about the Governor's Commission on Alcohol and Other Drugs and describe the oversight of those funds and how they're used?
Absolutely. So the Governor's Commission is in statute. And so all of its obligations and what it does is defined in that statute. It is determined who's on the commission is listed in that statute. So that includes appointments from the governor and specifically seats that are designated. For example, the Commissioner of Health and Human Services, the Commissioner of Safety, the Commissioner of Education, all sit at that table. People with lived experience, their representation from recovery and from other types of programs. I serve as the executive director of the Governor's Commission by statute. And so that is part of the attachment that they have. We administer and carry out the wishes of the Governor's Commission. The Governor's Commission is extremely transparent, and because of questions that came up from Fiscal Committee a number of years ago, you will find in the operating statistics in the dashboard for every single month of Fiscal Committee, we provide where we are, all the status of every single contract that is funded by the Governor's Commission. The Governor's Commission provides annual reports. We have a strategic plan, and we have members of the legislature who serve on that commission. It is a high functioning, mature group that not only makes decisions based on their own self-interest, but we have had sessions, listening sessions going out across the state to hear from people about where they think the gaps are. And we just did that last year. Very informative and really helps us build our strategic plan and target dollars towards those gaps. One of the benefits of the Governor's Commission is that its funds are flexible. So we've been going through, we have the block grant that has a set aside for a certain amount of dollars. We have obligations under and all the strings that come with federal funding. The Governor's Commission has more flexibility, but it also has accountability. I just think that it is an example of how we can structure such commissions that have that funding authority and that appropriation authority, allocation authority. And so I hope that answered it. And I know Nathan wants to add something.
Yeah, I think one other important thing to understand is once that commission makes their decisions on what should be funded, Katu's team, members of my team, then develop the contracts using the standard contract process and template that we use, where there's performance metrics, we look at deliverables, we look at the payment terms, and then once those get approved and all of our contracts are scrutinized by the governor and executive counselors, then those services are delivered, and then they go through the standard monthly review process where we're verifying that the services are received, and we generally do not pay anything for a cost reimbursement based contract or other deliverable contract if the services are not demonstrated and delivered. So there's also sort of the micro level side of it, both at the global when the decisions are made, but then once we actually implement and operationalize it, there's the same level of scrutiny applied to that as any of our other contracts and grants.
And we also do often go out to bid for those services with the Governor's Commission identifying that they want a particular type of service provided, but we issue an RFP so that there's opportunity for community organizations to put in their applications for that.
I appreciate that explanation. So any other views that for some reason these funds are not being managed properly, it goes through data-driven metrics the same way other spending does for the department. Perhaps we just have to share this tape and help them better understand how that works. So thank you for that.
Representative Nevelenko for a question.
Malavenko. Yeah, so that's kind of new to me. I think you said 5% of the Liquor Commission sales are allocated to that fund. And so the question is, this is a fund that's constantly receiving funds. I would assume on a monthly or a quarterly basis. And there's a budget for the Governor's Commission. And to the extent that that's over or under, so I would assume that that fund always has a positive balance. Is that correct?
So yes, however, we do, again, during that monthly report, and we share this with the fiscal committee, and we also have the dashboard that we share with the Governor's Commission that shows what's been carried forward. So this is a non-lapsing fund, what's been carried forward, but what also has been obligated. So they're making spending decisions usually twice a year. If something unusual comes up, they'll make a special, they'll do it in an off time of those 2 meetings. However, that balance is always known. And right now, for example, with the anticipated funding, or the actual funding and the allocations that have been made by the commission. So it takes time for us to go into contract. And so they may have voted to direct funds to a specific type of service, but for us to be able to execute upon that may take several months. So right now, for example, sitting here today, we have about $1.4 million that is unallocated, and that is available for consideration for spending. The commission has taken a conservative approach in that it wants to have a little bit of a balance to account for an emergent situation. So if we have something that really needs a response, they like to have the flexibility to be able to respond to that. So they don't want to spend it down to zero. We have gone to $500,000 before, but yes. And from the Liquor Commission, as to, we always have these replenished funds. I believe that they make the payments to us twice a year.
So you roughly have a target for what you'd like to see as a unallocated balance that, on an ongoing basis, again, varies by whatever the needs are.
Yeah, I think it's not uncommon for it to be around 10%, but again, it can dip below that. And if there is an unmet need and we know there are dollars there, they're going to allocate it.
A related question, and probably because I haven't kept up with it, but there was a tobacco settlement fund, right? And is that totally gone, or is that still something that's out there as well?
We typically do not use the tobacco settlement funds for public health or other primary prevention services. There are small amounts that may fund individual things, but as a whole, the tobacco settlement funds typically go into the general fund, although I'd be happy if someone else knew more than that.
Okay, thank you.
All set.
All right, so I think we're at page 50. And we're going through, we should have said at the outset, and I apologize because you had to raise it yourselves, but we did do a lot of work in cleaning up these accounting units because of what Nathan said about really being able to identify for grant purposes and reporting It is much cleaner to have 100% federal funds in an accounting unit and then 100% general funds. And so the team that is here with Nathan and me today took a considerable amount of time to move those funds around, and you're seeing that in your budget pages. So I apologize for not raising that, but thank you for noting it. So drug forfeiture, this is when we get a percent of when there has been a seizure and through a criminal activity, and there's the forfeiture of the goods, so to speak. Those funds are given to us and put into this account by statute. And so we're able to use those. It's not a lot of money, but it is available. State Opioid Response Grant. This is the funding that comes from SAMHSA, and this has been in play for several years. We are in year 4 of allocation from this grant, and it runs around $28 million a year. It is categorical in that we have very specific areas that we are allowed and not allowed to spend these funds on. One key component that is loosened up a little bit, but still remains, is that it's for services for individuals with opioid use disorder. And so, or at risk of opioid use disorder. This funds our doorway system across the state, so our 9 doorways that we have. And it funds a number of programs. They have specific populations that they want to have addressed, including justice involved and pregnant moms, parenting, people who are parenting, and we use it in about 30 contracts. We're in the process of doing the renewal with the latest funding that we received in the last quarter of last calendar year. And I can see a question brewing.
It's already brewed.
Representative Nelevenko.
Yeah, I'm looking at a big drop in those numbers from, I'm on page 998, and I think I'm looking at the current expenses 020 on state opioid response grant goes from $1.4 million down to pretty much smaller numbers. What's the story behind that? I'm on page 998 of the governor's budget.
Just looking at line 20.
Yeah, line 20.
Oh, that's the job.
The current expense line there.
Yeah.
So, cut.
I don't think it is it?
What's that?
I don't think it is. I don't know what current expense is.
Overdose prevention. That's what's paid.
Yeah, but where did they go?
Yeah, we just budgeted.
Basically, you're talking real money.
Based on-
I think for this, we're going to dial a friend. So I'm going to ask our finance director for the division to approach, and if Kyra Leonard could help us with this.
Sure.
She didn't come to spend all day without speaking.
And if you could just introduce yourself for the record.
Kyra Leonard. I'm the finance director for the Division for Behavioral Health. Sorry.
Welcome.
Thanks. And we're looking at the class 20 line in 74. So the reason why it's so high with the actuals in fiscal year 2024 is we ended up buying a large amount of naloxone for distribution into the community to increase saturation. And then it went down because we're accounting for buying additional, but not to that extent. So
So I think we saw this was on grants to communities across New Hampshire. Is that what happened there? Oh, she
Is that a
went away.
question for, oh,
Yeah, it
would
was.
you
Was that-
yield
that-
to a question?
So I can answer that. So we purchased naloxone, and so we had naloxone in every doorway budget where they would make their own purchases, and then we, as a state, made this particular purchase of naloxone, the reversal drug, and the contracts that we're talking about show up in other class lines.
So that's something that our local communities would have seen. So for example, in my town, we have an ambulance corps, and I think I remember something about saying that they were, stocking everything with that particular drug. Is that where that would have come from?
Some of it, yes. Some of the private, so the communities already have a variety of pharmaceuticals that they need to have on board for an ambulance, standard type, saline and different things that they have. And so that a particular ambulance may not have gotten naloxone through our distribution. Many of our community service providers are the ones who are the recipients. So it may be a community-based organization. We've had churches, we've had schools, we've had service providers, welfare offices, many who have utilized the distribution and been able to access naloxone that way.
So my local ambulance service in Elstead is stocked with that. They could have gotten it either directly or via one of the people we partner with in the community, or
Yeah, I can't.
I know I'm
speak-
just
Yeah, I can't speak specifically. It's possible, but like I said, the idea was to have it be a community response and for community members, for lay people to have access to it, and not those who already were using that for years and years and years. But for your specific case, we could find out if
that's not necessary. The good
Yeah.
news is they have it, they stock it, and they use
Absolutely.
it.
Yeah, yeah. All right, anything else in these accounting units?
Looks like we'll move on.
Okay. So now we're at the unnumbered 51. Similar structure as we've had with the previous bureaus, talking about everything from community education and awareness up to the crisis level of service. We have the 211. We have the regional public health networks. There are 13 that we partner with public health in helping support. And they in turn are the regional hub for these types of services in doing community assessments and identifying needs. And they help coordinate services in their regions. We have the juvenile court diversion programs. There is prevention and early intervention, and this is starting to go up the scale. So you have assessments, you have youth prevention projects. If you've Governor's Commission has had a couple of youth groups present on the funding that they've received and being able to share with us the work that they do in their communities. It's incredible. So if you ever get a chance to go to your local middle or high school and see some of their prevention programs, I highly encourage it because it's really hopeful and positive impact on the school, the students, and the communities.
Representative Priest for question.
Thank you, Madam Chairman, and thank you for taking my question. Back to community education and awareness, could you just walk me through the juvenile court diversion program that you have? I'm not familiar with it.
Yeah, so there are community-based organizations that have programs that really look at youth who are at risk of higher levels of criminal justice involvement. And this is a way to identify them and divert them from that additional level of involvement. And so I can get you more information about the specific programs, but that's really what that program is. We have several community-based organizations and they're part of a network. And this is something that the DCYF field staff are, and the and juvenile justice, I believe, Director Noonan would be able to talk about the value of these programs. Peer recovery and peers and recovery supports. So we have two different peer systems in our division. So we talked about the mental health peer organizations, and we have them in substance misuse as well. And so these are known as the RCOs. We have funding specifically for those organizations. There are, I forget how many locations. I know it says 4 contracts here. We have a facilitating organization. Harbor Care provides the services for administering and subcontracting with our recovery community organizations throughout the state. We have recovery residences. This gets back to the question from Representative Stringham and about what is our oversight? What are we doing? How are we looking at recovery? And we do support those that are certified. There's the Recovery Friendly Workplace, which was a Governor Sununu initiative that has taken off. And those are workplaces that have deliberately gone through a process to be deemed recovery friendly and work with helping individuals maintain their employment and to help encourage and recruit people in recovery and help them with their recovery efforts so that they can be productive workers. Community-based services and supports. We have the outpatient treatment. We have the doorways. I want to talk a little bit. We did not do a slide, and it was, I noted it this morning, about the opioid abatement programs. So in addition to the Governor's Commission, there is now an opioid abatement trust fund commission. And that was established when we started getting settlement money with the lawsuits against the manufacturers and the pharmaceutical companies that contributed to the opioid epidemic. And you probably have seen headlines where, millions of dollars of settlements. And so the state established a trust fund, and there's a commission that was legislatively created to be able to oversee those funds and to make allocations of those funds. And so they've been up and running. They also have a dashboard similar to the Governor's Commission dashboard that is available. They make funding decisions and have made significant investments in housing is one area that they were looking at. They've also made smaller community investments in different programs. Perhaps some have been mobile vans. One has been to help with the purchase of a piece of property for services. So they have different ways of being able to allocate those funds. It is not in our budget, and Nathan can explain that.
Sure. The opioid abatement trust fund, it's a dedicated non-lapsing continually appropriated fund, and that commission directs the department to utilize that money, and they meet regularly, and the department does not individually make decisions on how those funds are used. That's part of the Under statute, that's how that's decided.
Representative Telersky for a question.
This maybe isn't even relevant to our division. However, in the draft of HB2, there's money from the opioid abatement trust fund that's being directed towards law enforcement at the northern border. Can you, I know this is not your wheelhouse, but maybe talk about those funds and how they can be used, and if, I think in the past, discussion of using them for law enforcement was not a very popular idea.
We can't comment on
Right.
that just because it is out of our wheelhouse.
Yep.
I can say that the purpose, the use of the funds is dictated by statute and by administrative rule.
Okay, thank you.
Representative Navalanko.
Nalavanko, we'll get it. The question I have, what's the, is that a one-off fund? I mean, the money in that fund was created by a one-off settlement, or that's a continuing funding source? And then the other question is, same kind of a question we had on the governor's commission fund. What is the roughly the balance in that, and what kind of budgeting do you do against it? You like to hold a reserve, or what's the financial picture on that fund?
Sure. So we receive settlement funds in different ways depending on the lawsuit and the success of how New Hampshire participated in that lawsuit through our Department of Justice. And so we've received one-time funds of, small amounts, and we've received multi-year, multi-million dollar awards. So from the settlement. So we have awards that are expected to be made for up to 18 years or 10 years. It depends on the nature of the settlement. And so we can project when we're going to receive funds based on an actual settlement and what New Hampshire has been allocated. There are still pending lawsuits, and we expect that will continue for a period of time. And we're fortunate that the Deputy Commissioner of the Department of Justice is now the chair of the Opioid Abatement Commission, and he's able to give us updates at each of the monthly meetings. The commission is much newer than the governor's commission, and the amount of funds, I believe, we have received somewhere around $50 million, and the current balance is roughly, that has not been allocated, and it excludes, it already, I'm accounting for this, is that the amount in the budget. So if you take all of that and you look at what's unallocated and decisions to be made on, is about $11 million is the balance.
Okay, thank you.
All set on this subject? All right, proceed.
Okay, I'm not quite sure where I should go next, but I think we were talking about getting up to residential treatment and housing supports. So we have different allocations and in support for particular programs that have to do with alcohol and other drugs. I should go back. I want to tell you that the doorways, when I talked about that categorical funding and that's specific for people with opioid use disorder, we found and we know from the data that individuals, the most used or misused drug in New Hampshire is alcohol. And so we had people who were appearing at doorways that were 100% state opioid response grant funded and didn't have the funds to help support those individuals who only had alcohol use disorder and no history of opioid use disorder. So the Governor's Commission, some of their funding helped support the doorways for those non-SOAR funded allowable expenses. So I just wanted to mention that as a way that we're really crosswalking how we breed funding and pull together the pieces so that we don't have those gaps for people based on our funding source. We help support our treatment programs. We talk about the residential treatment, inpatient treatment. We help with room and board. Medicaid doesn't pay for room and board when someone enters a course of treatment in a residential setting. So the state opioid response dollars are able to go towards that room and board. We mentioned there is that crisis respite when someone's ready to enter into treatment but doesn't yet have an admission or is awaiting admission. So we have those beds available. We help support the access point. Again, that's for people experiencing a substance use crisis as well as a mental health crisis or a mental health crisis. And as noted, we carry out not only the administrative functions of the Governor's Commission, but also of the Opioid Abatement Commission. We went a little rogue on page 52 and don't have a wheel. We just have a fan to go through the same steps as we look at prevention, treatment, and recovery. On page 53, this is just some examples of the types of services that fall into those categories. So we have, as I mentioned, the regional public health networks, and you can see the regions. There's one in your region. I'm sure you can recognize it. And we talk about how many people were the partners. They convene those partnerships and those community-based organizations, and you can see those convenings. I will note that the business community is part of this and an important aspect, especially when we look at recovery-friendly workplaces. And the number of New Hampshire residents served, the educational trainings, and the youth-led activities. 54. So this is looking at community-based prevention. We know how important prevention is, especially in this arena. And so that's why you see a lot of focus. A few years ago, the Governor's Commission recognized that prevention was lagging behind everyone responding to treatment. And so they wanted to invest dollars in prevention efforts and actually had a very specific funding strategy around prevention services. So some of that continues, and you can see that here. School-based services on page 55. So we have
Representative Nelevanko for a question.
Sorry to be a nuisance here, but just a quick question on, of the 8 programs, I assume that you couldn't just take 8 and divide it into the 22,000, but so what would be the top couple of programs that account for more of the individuals, and what areas do they serve?
So unless someone behind me stands up, I'll have to get back to you on that.
Okay, because I assume it's regional or.
Yes, yeah, those 8 programs, yeah.
Okay, thank you.
I have had staff here to support me, which has been amazing that they're sitting here and having to listen and probably saying, ooh, you should have said this. But it is school vacation week, so we've had some absences, and our Bureau of Drug and Alcohol Services Bureau Chief was here earlier. I don't believe she's here now, but she is a prevention queen, and I'm sure she can answer those questions off the top of her head. Is somebody standing?
No standing.
Okay. All right, 55, again, school-based prevention. These are school districts that have voluntarily and eagerly adopted programs to address substance misuse. Student assistant programs are coordinators that are at middle and high schools across the state. And they're supported. There's health and evidence-based curriculum that is supported, multi-tier systems of support, and we have the collegiate tertiary prevention. That was an area of particular interest that we heard over and over, that we were focusing on middle and high schools, but we're finding that college age students that was their first experience with substance misuse, and that we needed to put some support in there. So that's what that's about.
Representative Priest for a question.
Again, as a clarification, the school-based prevention not only covers public schools, but also collegiate schools in New Hampshire, right?
Yes.
Okay, thank you.
And a quick question on the collegiate tertiary prevention. That's in conjunction with, so again, how's that structured and, you know, who does that, does it touch University of New Hampshire or
Yeah. And
SNU?
right now it's UNH based with the plan to expand to other university system campuses. So yeah.
So it's a pilot program at this point? or-
Essentially, yeah, I would say it's pilot with the plan to scale up. We do plan to scale up.
Thank you.
So,
Representative Priest for a question.
I guess-
Yes, going back to the numbers for alcoholism, and other drug abuse programs, do we have any numbers of what the population is out there and what percentage have sought help from you?
So I think there are two different ways of looking at. There's the percentage of individuals who've been served. It depends on how you look at being served. Is it in a treatment program? Is it through recovery housing, through whatever service? So that's one way to look at it and to slice and dice it. I think also there are the statistics that have been done based on anonymous surveys about how many people actually have alcohol use disorder or opioid use disorder in the state. And those are very different numbers because not everybody who has a disorder needs or wants some type of service that is funded by the state.
And are those numbers available for us to look at?
I believe they are through our public health partners. We have some statistics on that and be happy to share the link to the website that has data that you can look through yourself.
That would be very useful. Thank you.
You're welcome.
Just a quick follow-up question on that occurred to me. So do we partner with, I mean, the traditional organization that I, kind of grew up with was Alcoholics Anonymous. Do we partner with them or do we fund them or how to, what's the relationship there?
So we do not fund specifically AA programs. There are AA programs that are available to people through throughout our whole system. But I think the very nature of that particular program is the community-based and I don't know how to describe it, but there's no funding involved. If someone wants to participate, I think that there is community support through churches for locations and through all the different public facilities and other organizations that host them, but we don't specifically fund AA programs.
That's kind of curious because I've always, the feedback or anything you've seen on that, there's very effective program. And, it just seems strange that we wouldn't somehow cooperate with or fund them other than, indirectly through community groups. But anyhow, that's just a side comment.
Many people find recovery through such programs and through other avenues. So it is part of the ecosystem and how people receive the help that they need, and that they're able to find recovery through those programs.
Thank you.
All right, we're getting down to the wire here. So page 56. This is overdose prevention. We've already talked about the naloxone distribution, and you have the drug deaths by year. We didn't add 2024 because the numbers weren't finalized when we did this, but they continue to go down year over year. We did see the increase in 2022, but then we've seen pretty remarkable drops since that time. We have attributed that to all of the programs that are in place, most notably the distribution of naloxone, so that we are preventing deaths when there is an overdose, and access to the medication for addiction treatment. So that has been in a couple areas that have been highlighted as contributing significantly to that reduction in the overdose deaths.
And just an observation, but we've heard a lot and we see a lot about fentanyl and fentanyl deaths. So I guess I'm kind of surprised to see that the statistics, I don't know, that's worked into the statistics, I presume. So that seems like a disconnect from, all the reports that you hear about the fentanyl crisis and how deadly that is. And I don't think the naloxone doesn't work on fentanyl, does it?
It absolutely does.
Oh,
yes.
it does?
Yes.
Okay, so
there
that-
are other, so it doesn't work for all drugs that may cause an overdose, but with fentanyl, it is effective. We just had the Governor's Commission just had a meeting on Friday, and we had a report from the Department of Safety, and they shared with us the state lab. So they have all of the details about the samples that they were given to test and what was found in those samples. So was there meth? Was there cocaine? Was there, you name the drug and the combination thereof. It's a great report. And so they did that. Can get that to you, point you to their website. And they also provide a monthly drug monitoring initiative report, which takes information from a variety of sources, and they get it from EMS, so the statewide EMS system they're able to pull data from, and they know how many across the state, how many responses there were to individuals who had overdosed. And then you take the state lab information that's included in that report. You take the treatment admissions that are in that report. So it's a wealth of information that is provided about the current status of what's happening. And what we're always looking at, and the state police and the Department of Safety really talked about what they're seeing on the street and what's up and coming, and the concerns that may arise as there are different combinations of drugs that are out and put into distribution and are of great concern. So we partner really closely with the Department of Safety.
I guess the other one is probably a misconception on my part is that, and there's been a lot of discussion in this term about marijuana and medical marijuana, or, legalizing marijuana. And maybe it's a misconception on my part, but I was, my understanding was that the marijuana isn't the same marijuana that I may have experienced when I was college age, and that it's sometimes laced with a lot of other stuff. So is that a misconception, or is it some aspects of marijuana use that overlap with the whole mixture of other things that are out there?
Yeah, and the people from the state lab did present some of that data. What they indicated was when you look at it, because it's no longer a criminal penalty for marijuana or for cannabis, that they're not testing as often for that, but it does come up in that polyuse of different drugs and lice. I'm not the expert on that
Yeah,
particular.
I understand. Thank you.
Yeah.
Going off of that, there hasn't been a whole lot of talk about smoking in general in your department, whereas we've reached all other sorts of topics. Any remarks regarding that?
So that is something that we have had efforts around. I would defer to Associate Commissioner Trish Tilley, who is here from a public health perspective, where there are programs around that. We also have had efforts around our community mental health system, because individuals with mental health condition have been known to have an increased risk associated with smoking and with tobacco. If Trish is here and she wants to comment, but it is something that is certainly on the radar.
Sure.
And-
Ms. Tilley, if you'd just like to have a seat.
Hi again, and thank you, Patricia Tilley, Associate Commissioner at the department. Thanks for that question. I think we can dive into that a lot more on Tuesday when Public Health comes and talks to the committee. Our tobacco prevention and control program is in the Division of Public Health Services. We've had a long partnership with the Division for Behavioral Health, as Director Fox had noted, because of the disproportionality of people with mental health or behavioral health conditions and tobacco use. And so we have strategies to be able to connect that both in quit line services, as well as just sort of the structural environmental around having appropriate tobacco related policies in among the different programs that serve people with behavioral health conditions. So it sort of comes at from both ways. The issue, of course, many people have been thinking about is vaping. So our tobacco program also covers vaping, in particular for adolescent use. And we saw that dramatic rise of vaping during the pandemic. We're happy to see that the youth rate of vaping has come down. It's still too high, but we did have a peak in about 2021, and we're on the other side of that now. But there are lots of unknown questions about the impact of of vaping, those chemicals, the nicotine use, and what that might mean for addiction later on. So more to come on Tuesday.
Thank you. We'll look forward to that on Tuesday. Budget Work Session, Division of Public Health. Representative Talerski for a question.
Thank you. It's my understanding that the progress we've made with overdose prevention can be tied to Granite Advantage and the Medicaid supports that we have for people with substance use disorder, because we've seen the numbers drop as your chart indicates right here. And I guess my question goes to, you mentioned it points to naloxone access, but also medications for treatment. So I guess the conversation again on the Medicaid changes to both the prescription copays doubling and just simple access to the Medicaid program raises some alarm for me that we may have a setback. Can we talk a little bit about how someone who doesn't have coverage or can't afford their pharmaceutical copay would be able to access medication for their treatment of substance use disorder? And how that may affect the overall picture.
So when I talked about and actually this ties into the slide that we're about to go to and talking about treatment. So the department does contract with treatment providers, and as part of that contract, it covers non-billable Medicaid billable services. And so so there are people from the federal poverty line of 138 to 400% that are covered by these contracts, as well as those that are uninsured and underinsured. And so the providers are able to, through demonstration of the need, bill against those contracts to be able to fill those gaps. I am unsure of the impact that a change in expansion would have, other than when we first had these contracts, there was not a benefit for SUD services through Medicaid until the ACA was passed in 2014. And so before we paid, almost all of the services were paid through these contracts. Over time, we were able to shift what we were paying for these treatment providers because of the Medicaid coverage. People were covered and they were able to bill Medicaid rather than bill against the contract. So we saw a shift in the way that we were paying for those services. And we would expect that there may be a shift back.
So that's a tiny bit of better news than what I thought. But is there a ceiling on those contracts? Like, is there a way those could get maxed out?
The ceiling is met today.
Oh.
We ask for the funds and they expend them. So it is all dependent on the allocations that are made here, the
Thank you.
appropriations. Okay, so slide 57. You can see the numbers here, the numbers that are served. These are not every single treatment provider in the state of New Hampshire. These are the ones that responded to a request for proposals and have entered into contract with the state. So this wouldn't be reflective of all providers in the state. There are some that don't accept Medicaid and they may accept Medicaid, but they choose not to contract with the state.
Representative Nalvanko for a question.
Yeah, very quick question. Does behavioral health also cover gambling addiction? I mean, that's another, it just kind of struck me as being notable by its absence on this. And then is there a separate, are the casinos funding some kind of a separate fund for gambling addiction? And what is that and what's in it?
So I'm not sure if the LBA wants to comment on that.
Sorry, I was in the midst of responding to an email. What was
Yeah,
the question?
No
again?
problem.
Sorry about that.
I can let you know. So he was asking about the gambling and whether we, if there's an allocation through the state to address addiction to gambling. And I know there is. It, at one time, I believe, was going to be attached or was attached to the department, but now it is overseen by the Lottery Commission, I believe.
I'm not sure about that, but I can check with Mickey Landrigan, who does Division 1, so he would know about that through the lottery division, through the Lottery Commission. So I can get you an answer to that.
But it is a behavioral health issue. I mean, for sure. So, I mean, I would just, as I said, it was notable by its absence from any mention of it all in the presentation. And whether or not you all are dealing with it with any programs or that's a totally separate,
There is funding, and it does go, I believe, to the Lottery Commission, and it funds programs for that, addressing that. I think it was the source of funds that really contributed it to being it with lottery versus the department.
yeah, but I mean, that's been an expanding kind of a program. It was lottery and then it went to, the casinos and my understanding is that the governor's proposed budget had money in there for slot machine, a pretty big chunk of money in the budget towards the end of the second year of the biennium. I think 127 million.
That's exactly the estimate, right?
That was the estimate. That kind of was used to balance the governor's budget. So
Right. So I think that you'll get the information about where it is in the budget and what it funds and how that's what percentage and that kind of thing.
But it is something that probably you have on the radar to be dealing with on the behavioral
Absolutely.
health side.
Yes.
Proceed.
Okay. So we are closing in the recovery. We've talked about that a little bit. We have the peer recovery support programs, and you can see how many individuals that they've served. The recovery residences, the ones that were certified. I talked about the certifying body, and that assures that quality standard, and then the recovery friendly workplace. Now, state opioid response is another separate slide here. We've talked a lot about it. Sure.
I just want to back up.
Representative
It's me again.
Navalenko.
What is, what, kind of give me a feel for what a recovery-friendly workplace constitutes.
Absolutely. So there is a program in which a business can be deemed a recovery-friendly workplace. It is, I'm waiting for someone to get up behind me.
No
and-
such luck.
No, that's okay. I don't need them to, but I heard footsteps. So it's a business that wants to be able to attract and maintain staff. And as you know, there have been staffing shortages across a whole bunch of different fields, including manufacturing and in healthcare settings. And by deeming themselves and going through a process where they go through a checklist to make sure that they have the right components in place to be part of this program, they're able to advertise that and then really help and give that assistance to the people who work for them, so that they don't lose a job, so that there's not the absenteeism, so there is that active process in helping them in their recovery and maintain recovery. The state of New Hampshire, the department is a recovery-friendly workplace, but there are many businesses, and there's a long list of businesses that are part of this program.
Okay, thank you.
All right, state opioid response. I think we've talked a lot about this scattered throughout all of the programming, because we have braided funding and have built upon efforts that have either were started by that particular funding source, or that we're able to enhance and support and augment with that funding source. So the idea of the doorways, they're strategically located in 9 locations so that it is easy for people to access services within an hour. Any other state or populated state, you'd say an hour. I'm not going to take an hour, but in New Hampshire, we know an hour is pretty close. And that there is an increase in standardization of services, and that the main goal is to decrease the overdose deaths. So that is something that we're measuring against. And we fund, as I said, I think it's about 30 contracts that are going through that contracting process right now. We have the doorways that are open during typical daytime hours. They're in hospitals, hospital-based locations. And then we have an after hours, so that if someone's in crisis, not only could they have mobile crisis and call that, they also have the clinical coverage where they can get some supports until they can get to the doorway physically the next day. So we do that through 211. Again, medications comes up here. We are able to support those medications for treatment. We have a collaboration. Yesterday, I was before the Executive Council with an MOU with corrections so that we're able to support the services that they provide to individuals who are transitioning to the community. So that includes naloxone, training on naloxone for staff, and some other services that are able to be provided by DOC. Recovery housing, crisis respite. We've talked a lot about some of these services. And we do have a relationship and are able to provide some assistance to the Drug Overdose Fatality Review Commission, which looks at cases typically that have been closed and brings the parties that were involved in that particular death together so that they're able to learn from that process and to be able to make any policy changes that are needed so that we can do a better job as we go. And the last slide. Just reviewing our prioritized needs. So as you can see, we did very well with our prioritized needs. We are very fortunate to continue to receive the support from the governor and hopefully the legislature as we carry out the functions and the needs of individuals with behavioral health conditions. We had the uncompensated care, the $5 million in each of those, each fiscal year that was noted, the shelter rate increases that were done in this state fiscal year, and those will continue to carry forward if they remain in the budget to keep at that $27 per bed per diem. We have the Waypoint shelter that was funded. One area that you'll be hearing more about, I'm sure, from the community is guardianship services. So we had asked for additional funding to increase the number that they're able to serve as well as the rates, and that was not funded. And then we had, as we referenced, 1573, HB 1573, that we received some funding. That funding will stretch through the biennium, but not for the last 6 months. So that was a prioritized need that we put in to be able to cover that last 6 months for that increased oversight of residential programs. And so that was put into this budget. The cross-divisional with DCYF, we talked about the provider rates and whether there was an increase for the rates. And so the rates were not funded, but the amount that we need to make up for a loss of federal funds was in part supported with half the amount that we asked for. We asked for 18 million and we received 9 million.
Representative Priest is recognized for a question.
Thank you, Madam Chairman, and thank you for taking my question. Going back to the guardian services, could you just give us a brief explanation of what that is?
Sure. So there are individuals who go through a process of being determined to need a guardian to make decisions on their behalf. And so in the behavioral health field and with individuals with intellectual disorders, they are appointed guardians. And so the guardians are provided through 2 contracts that we have. And so that's an area that is typically underfunded and needs support.
Would one of those services be CASA that you?
CASA is a very, very important part of the child protection and child welfare system that is not covered here.
Representative Nalavankos is
Just a
recognized for
follow-up.
a question.
That's court appointed, or is that outside of the courts, or is it a combination of both?
I will defer to that. I believe that it is deemed, you have to you have to go to court to get a guardianship. So if I had an elderly parent and I wanted to be their guardian, if they didn't voluntarily, petition or ask for a guardian, then I would go to the court and ask for guardianship. But if I have that wrong, I'll make sure that we correct that.
So I'm just curious on the funding of that. Is it, and I don't have a great understanding of that whole process because I've never had to go through it. But if it's court appointed, are the costs any other places in the state budget where that's covered, legal services, or is it entirely in this area of the budget?
We have other costs throughout our budget that are the result of court-based decisions. I mean, children entering the DCYF system is a good example. Earlier, we were looking at an accounting unit that had assessments that are required. So it's certainly not that unusual to have a cost be driven externally.
Okay, thank.
All right. I think that concludes our presentation for today. There is a lot of information that's in my head that didn't come out of my mouth, and I'm sure you have a lot of questions that you hadn't yet articulated. So be happy to answer and respond to the questions you did ask today, and to be available for any other questions that may arise.
Thank you very much for that very thorough and detailed presentation. We truly appreciate the time you took not only to present it, but to prepare it. We are very mindful of the hours that go into a presentation like this. It's like I used to tell my students, you see the teacher in the classroom, but that's not all they do. There's a lot of behind the scenes that have to be appreciated in terms of the time and talent that it takes to actually appear, and you have done that. So thank you very much. Representative Preece is recognized.
Madam Chairman, I would like to kind of second what you have said. Thank you again, Ms. Fox and Mr. White. Very thorough program, and thank you for all the services that you and your division are doing. Thank you.
If there are members with us today who would like to make comments, what have you, you are welcome to do that. Please give our presenters some time to clear, and then come up and do make your name and who you represent clear. Thank you. Welcome.
Thank you, Representative Mooney. I'm Jim Monahan with the DuPont Group, and though I represent and work with a lot of folks in the Medicaid system and will be here quite a bit, I did want to focus a bit on my, if in case of listening on YouTube, my favorite client, the Community Behavioral Health Association, which is the 10 community mental health centers. First of all, let me just echo what the committee's already said. We really see the work that we do with the department and the Bureau as a partnership. The 10 community mental health centers care for about 50,000 people a year. The vast majority of those are the vast majority of the funding for that comes through Medicaid, and our working relationship with the department is excellent. And so I appreciate, just as you have, the work that Katja and the team put into the presentation today. I'll be relatively brief. I just want to highlight the committee to three things that we'll be asking for in the context of the budget above and beyond what you've seen in the funded priorities. The first is we are joining with other providers in the New Hampshire Healthcare Workforce Coalition in supporting a 3% rate increase for Medicaid providers in the upcoming budget. Many in this committee might know that a lot of work was put into a pretty significant adjustment in rates in the last budget. Our hope as we move forward is to come in with modest and needed rate increases each budget cycle, so we're not here in desperate straits every 10 years. And so we did survey the provider community across the 23 rate cycles that we went through in all those spreadsheets 2 years ago, and remarkably found that with very few exceptions, many felt as though the 3% was what was needed and didn't ask to go above and beyond that. In addition to that, the community mental health centers have legislation pending in the Senate with an appropriation on it that deals with some very important housing issues. As Director Fox pointed out on a number of occasions with you all, for many of the folks in Medicaid that we care for, room and board are not Medicaid allowable expenses. And so oftentimes the community mental health centers that run those programs have to struggle to put them together. So there is a Senate bill that asks for general fund appropriation to support that activity. And to be honest with you, I do not remember the bill number, but we'll get it to you. My expectation, and it had a favorable recommendation in Senate Finance, but I presume that they will, as with many items, pass it out of committee and table it, waiting for the bill to come over from the Senate. And you'll see that whole laundry list, I expect, but our hope is this one is on top. The last point that I wanted to talk about today is the issue of uncompensated care. As you heard from Director Fox and the governor, provisions have been made in the House Bill 1 as introduced to fund some of the uncompensated care that the community mental health centers are experiencing. The material that Mr. Ripple passed out is part of a work product that we undertook from the community mental health centers to figure out, we know we have uncompensated care, but where is it coming from? And so the dense spreadsheet organizes it by the 10 community mental health centers, and then the document you have here, which is a little dated, but it's outlined as a November document. The first part of it describes what is driving the uncompensated care, and it outlines the sectors which are outlined in the spreadsheet here, and they range from underfunding of Medicaid associated with the Medicaid spend down programs, concerns that the mental health centers are experiencing with regard to folks that have commercial insurance but can't afford and don't pay their co-pays and co-insurance, which, as you know, from the state law that you all have enacted and continue to act, that the community mental health centers, like some other safety net agencies, must care for folks that come in the door regardless of their ability to pay. So we're seeing increasingly, primarily the increasing coming from the commercial payers who have very high co-pays and co-insurance, but of probably more significant importance, they don't pay for necessary services that are the services that are provided to Medicaid recipients. So what we're seeing, if you look at the spreadsheet that I gave you in the far right-hand column, the very top number and the very bottom-ish number, is that in 2024, we experienced a $15.4 million uncompensated care hit to the community mental health centers, which, as you can see, amounted to a 12% differential when as compared to our Medicaid payments. What's remarkable there is if you look at from 2021 to 2024, it has doubled. It's gone from 6% to 12%. We are attempting to try to resolve some of the private payer issues and filed legislation in the Senate that I suspect is probably not going to advance this session, which would have charged an assessment to the commercial providers who are not paying for necessary care through the commercial products. We have failed to get the support of the Department of Insurance or the insurers for this approach, but want to continue to work on that. So among the things that we are working on and may be coming back to this committee with is a proposal that would set up a mechanism at the Department of Insurance to try to address some of the commercial carrier uncompensated care. But in doing so, we might ask you to front load the uncompensated care number that's in the budget. So rather than doing 5 and 5, front load it to 10 to stabilize things for the community mental health centers. And in that year of stability, we will be trying to work with the Department of Insurance to improve the situation with regard to commercial coverage. And then the last thing I want to do is I'm going to leave this for the committee and leave it on the table so that as you look at proposals that come before you, you look through I was going to write uncompensated care on this, but through the uncompensated care lens, that we are all looking for. So I know that there will be more comment on this next week, but when you take a look at some of the issues proposed in the governor's budget, which, we're still evaluating with regard to copays and premium contributions and the work requirement issues that are around, we want to be very conscious that that the impact of those provisions are not to create more uncompensated care for the mental health centers. Recognizing there's a state law that says we have to care for folks regardless of their ability to pay. If they lose their coverage because of administrative burdens around a work requirement or because the family is unable to pay a premium, the impact of that typically falls to the provider. And for providers that can't deny care for people, it really just gets absorbed as additional uncompensated care. So those are things we'll be hoping to work with the committee on over the next several weeks and in several months when we bring the Senate into it. But I wanted to thank you for the opportunity to alert you to those today.
Thank you very much. Yes, be sure to leave that magnifying glass in a place where we can all find it.
Right there.
Any questions? Yes, Representative Navalenko.
Nalavanko.
Nalavanko.
It's actually just the way it would
You
be.
see, Representative, the deeper I am in concentration and the materials in front of me, the more likely it is I may
It's no
mispronounce.
problem. You're closer than a lot of in-laws. A question is transparency in pricing across, for procedures, all kinds of services that are provided in the medical health field, which I think contribute to the uncompensated, it's an uneven distribution. Some places charge X, some charge Y, and I assume that contributes to a level of uncompensated care depending on where you go for the service, whether you have insurance or you don't have insurance. And I'm just wondering whether you see potentially some of the reforms that are kind of requiring transparency so you know up front what you're paying for a service or a drug or that sort of thing. Would that play a role in helping to alleviate some of the issue that we have here?
It's an interesting perspective. I think you're looking for the perspective of the person who's purchasing insurance and whether or not there's transparency in the coverage and in the cost.
Well, it's how you have an insurance policy and you decide to go to one place or the other. And there's a difference, I've seen it in my own insurance coverage, depending on where you go, the cost of the same service may be different at different hospitals or for different providers. And that in turn, I think, contributes to how much of it is funded or, funded or unfunded. In network, out of network. There's a whole host of arms and legs on this thing that I would think contribute to a certain extent, greater or lesser, on the so-called uncompensated care aspect of this.
Yeah, I think our first look at the uncompensated care piece in the commercial environment are services and codes that all commercial insurers don't cover. But beyond that, I think, and this is something Commissioner Betancourt deserves to try to figure out, which is I think I'm getting to your question, in some plans where there's a very high deductible or there are different levels of service, what the community mental health center would be reimbursed for the services could be different based upon the insurance product that the purchaser acquires.
Well, not just the insurance product, but what the providers are charging. I think there's differences there as well. And also it comes down to how things are coded. I think we've all run into the case where, you go to one provider and they're better at coding stuff in terms of an understanding of how the insurance situation works. And those that aren't as skilled at doing the coding result in different levels of compensation and then in turn uncompensated care.
Yeah, I think that's probably a level of the uncompensated care issue. But what we're trying to work out with the insurers is let's all get to the same playing field so that there's an agreement that you're going to pay for a certain service, and then it'd be up to the individual community mental health center to negotiate that rate.
Well, I come back to the transparency issue on, it's not just what are you going to compensate, but what are you going to charge? You know, if I have a choice between, you know, two places that charge different things for essentially the same product, I can make a judgment on quality and I can make a judgment on price. But as it is, you know, if I need treatment, I go and I don't really look at the cost consideration, because when you need the care, you need the care. But it would be helpful to know that you had an alternative, maybe same quality, lower cost. But I'm just throwing that out there because I think it isn't just an issue of how much the insurance company is going to pay and getting them all on the same page. It's the cost and the charge side of this as well. So there are two components of that, at least in my view and in my personal experience.
We're often quite careful in the way we work with the community mental health centers because we don't want to be engaged in any activity where the center should be negotiating those rates with the provider. So I don't disagree with you. I just think that's typically the, you know, kind of the business side of the community mental health center.
Well, this is all business, isn't it?
Right, but it's contractual business that has to be operated according to the regulatory rules. So, you know, I'll leave it at that.
Okay, thank you.
Thank you. All set? Thank you very much. Anyone else from the public wishing to address Division 3? Again, if you could just clearly state your name and who you represent would be appreciated.
Good afternoon, members of the committee. My name is Kate Fry. I'm the Vice President of Advocacy at New Futures.
And I'm Emma Savini. I'm the Children's Behavioral Health Policy Coordinator at New Futures.
We will be very brief, and I want to thank the committee for offering an opportunity for public comment. I also want to thank the department for their very thorough presentation. New Futures works on policy issues on health and wellness, and we have several buckets of work that will follow and we'll probably talk to you about during this process. But today, we are highlighting parts of the Division of Behavioral Services regarding the Governor's Commission on Alcohol and Other Drugs and Children's Behavioral Health. I just do want to support the Governor's Commission line in the budget. We are very pleased to see that the governor did fully fund that at the 5% level of gross profits from alcohol. Because of that, we will be able to continue some really important work that we have undergone in the state regarding substance use disorder prevention, treatment, and recovery. And as you heard from Director Fox, there is a very clear oversight process by the Governor's Commission of the expenditure of those funds and by the department. So again, we support that 5% allocation in the governor's budget.
And I would just like to highlight the importance of the Children's System of Care line item. You heard in depth this morning about that and how it helps children not just in their youth, but long-term better health outcomes across the lifespan. I'd also like to just underscore the importance of that Children's Behavioral Health Resource Center that you heard about. Not only does it provide resources to families in New Hampshire through the website, but it also provides important technical assistance to providers to help train up our workforce and be able to provide those critical services to families across the Granite State.
Thank you both. Would you take questions if there are any? Sure. Any questions from members of Division 3? All set. Thank you very much for your input and thought. Last call.
Well, just one quick one. If you have cards, or you could leave information, you know, so I have it for the record as well.
Okay, I think we're all set. This Division 3 meets again on Monday, March 3rd at 10 o'clock in this room. It's a budget work session on the Division of Economic Stability. Next week is very busy for the division. We're here on March 3rd, which is Monday, March 4th, March 5th. March 6th is a House session day. March 10th, March 11, March 12. All of the times that the divisions meet is at 10 o'clock, with the exception of March 5th. That's 9 a.m. anything further from the members of Division 3 or anyone else around the table. I thank you all very much. Hopefully your commutes home will be better than your commutes here, and we will see you again. Thank you all. We'll close this work session.